The recording will be posted on the board's webpage shortly after the meeting. TPW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Hang on just a second, Mandy.
No problem.
Okay. Welcome, board members. It is now almost 2:03 p.m. and I'm calling the July 30th meeting of the Healthcare Cost Transparency Board to order. I would like to give a warm welcome to everyone joining us today for our July board meeting. We've got a pretty large agenda, and I really appreciate that people carved out that extra hour, and that will help us keep on this journey about controlling healthcare costs in Washington. We're going to focus today on continuing our discussion on the facility fees, and we've got recommendations from the board's primary care committee, and we have some other work we've got to get to. As you all have read from many of the articles that we have been pushing out and from direct patient encounters, the facility fees have continued to be on the rise in Washington. It's an issue that we're going to have to dig into, study, and take some action on. Today's meeting is going to be focused on continuing the discussion on those facility fees and recommendations from the primary care committee. And we're going to talk, we'll have some data about the number of encounters with facility fees and whatnot. In 2022, just a snapshot, 1.3 million patient encounters with facility fees were reported to the Department of Health. That's a significant increase from 2018, which reported under 1 million patient encounters with facility fees. The amount reported in 2022 totaled $132 million. And as we know from our initial research, not all facility fees are required to be reported. So it's very likely that that number's a lot bigger. Again, something that we're going to have to keep getting more comfortable with and digging into and just continuing on our inquiry. So the other thing is that not all facilities are required to disclose these charges up front, leaving the patient responsible for all or a percentage of these costs that make them very unaware to the cost of their care and create significant financial hardships. As we've discussed, rising healthcare costs are one of the biggest reasons people delay or forego healthcare, making healthcare costs an underlying barrier to access for many. Washingtonians need members of our Healthcare Cost Transparency Board to keep identifying solutions to address rising healthcare costs. Just yesterday, Michelle and I participated in a national select meeting again to study just how come it's taking states so long to get these trends and costs under control. And I can just tell you that we certainly have a lot of factors. We've got some leadership changes going on with elections, both state and nationally. We've got a new insurance commissioner coming in. We've got studies that our industries continue to push back on and say the numbers aren't accurate, and we're all getting comfortable with this data and really having to work it together. So I hope that as we look forward, we can keep looking at how we are going to take action to contain these rising costs. And I think you'll see from the alignment that we've got going with the Purchasers Business Group on Health in their primary care report, that there's really some amazing evidence that shows that there are tactics that are working that improve things for patients, improve things for primary care providers. We also know that U.S. adults who regularly see primary care physicians have 33% lower healthcare costs and 19% lower odds of dying prematurely. We know that there are reports out that say that we could be saving $67 billion nationally each year if everyone used a primary care provider as their principal strategy for staying healthy. I mean, quite simply, we know this: healthy people cost us less. And so we really have to stay on this mission of bringing up these other strategies, all the while really continuing to investigate why are costs varying? Why are they sometimes unexplained, or how we can't get them to reconcile? So I think you're going to be really pleased with our conversation on primary care spending. And the two main policy agenda items today will really help us dig into options to increase transparency and to keep improving access to affordable healthcare. So I'd like you now to go to tab 1. And first, we always start with our roll call. And I'm going to go ahead and call out your name. And if you'll take yourself off mute, or if you're in the room, call out. Jane Beyer.
Here, thank you.
Eileen Cody, I know I saw you.
I'm here.
I think I heard her say here. Lois Cook.
Here.
Bianca Frogner.
Here.
Jody Joyce. Okay, staff, let me know if Jody joins in. Greg Marchand.
Yeah, hi, I'm here.
Thanks, Greg. Mark Siegel. Margaret Stanley.
Here.
Ingrid Ulrey.
Here.
Kim Wallace.
Here.
Kim Wilms. I didn't hear Carol.
Carol may be unable to attend today. I did receive a note.
Okay, staff keep us posted. And then Edwin Wong.
I'm here.
Thank you, Edwin. So staff, please alert me if we have any of our absent board members join. So let's go to our next item on the agenda, approval of the May meeting summary. If you will look at tab 2, that is where the information is. The May meeting summary is also being shared on the screen. Okay. As a note, I do want to remind everybody the recording of the last meeting is posted on our webpage for reference or review. And we'll use the consensus process for a vote on the approval of the meeting summary. Is there any discussion of the May meeting summary or proposed changes? Okay, I'm not hearing any. Is there a motion to approve the minutes?
So
I think that was Margaret.
No, Cody.
Oh, thank you, Eileen. Is there a second?
Second.
Thank you. All those in favor, say aye.
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 Any opposed? Okay, the motion is approved. Next, Eileen Cody, the chair of our advisory committee of healthcare stakeholders, is going to provide updates from the committee. Eileen, over to you.
That is, if I can get myself unmuted. Thank you, Madam Chair. We don't have a lot to say. We did have a meeting in June, and it was the first meeting since the legislation had been updated and the advisory committee changed to expand and include other healthcare stakeholders. We reviewed the purpose of the committee and the charter, and we had a discussion about medical debt and some potential policy ideas. Hopefully we're going to hear more from the committee members as in the meantime, and our next meeting is not until August. So that we're very brief, but that's where we're at.
We like brevity, Eileen. So thank you again, Eileen, to you and members of that committee. We're going to keep moving us right along. I want to welcome Janine Smith from the Health Management Associates and Bianca Frogner, the chair of our advisory committee on data issues, and they're going to be discussing facility feeds and providing updates from the advisory committee on data issues. Over to Janine, I believe.
Hi, I'm Janine Smith. I'm from Health Management Associates, and I'm gonna just sort of introduce our the topic, and we'll have Bianca join in on some of the discussions, because this was discussed and reviewed with the advisory committee on data just at their last meeting. Next slide. So as Sue was commenting, facility fees are important for the group to consider. They charge hospitals and clinics charge fees in addition to and not necessarily directly related to the services being provided. And as consolidation has increased, so have the use of the facility fees as, say, a clinic gets purchased by a hospital, and then they are allowed to bill under that hospital. As a result, purchasers and patients are paying more. And as previously mentioned, Washington reports that at least 125 million have been collected, and that is on only those that are currently being required to report. And the average facility fee, as noted in the 2021 and 2022 data, is about $100 per patient encounter. Next slide. So currently, all hospitals with provider-based clinics that bill a separate facility fee must report to the Department of Health. They have to report those four basic things: the number of clinics owned or operated that charge those fees, the number of visits at each site for which a facility fee was charged or billed for the year, the revenue received by the hospital in total by means of facility fees for those provider-based clinics, and then provide to the Department of Health a range of what those fees are. The hospitals do not report any additional information as part of their state licensing or any of the other facilities that are required to do licensing through the state. The Department of Health only on those licenses ask if they bill under a hospital or health system. And in the midst of the certificate of need regulations, there is no facility fee information collected. Next slide. So what is not reported currently? And Bianca, did you want to talk a little bit about this one?
Sure. Thank you, Janine. I think Sue kind of teed us up a little bit earlier too about talking about some things that are not reported, but so what is not being captured is all the entities or locations that are charging a facility fee in the state. Only hospitals are required to report this data, and only for some certain types of facilities. Washington does not require notice of facilities fees charged by providers not affiliated with a hospital or health system. It's likely that there are significant amounts of these facility fees are not being reported to the state. So as Sue said earlier, that it's possible the numbers that we're hearing about are underreported. And it's not clear which off-campus entities might be charging fees, who might be and how those fees get across to patients versus those who are actually providing services on a hospital campus. What's not captured are what services specifically have facility fee charges attached to them. So there's no detail on what services are associated with a facility fee. So there could be some facility fees attached to preventive or telehealth visits in an outpatient setting if a practice is part of a hospital or a health system. Also, we're not able to quantify the impact on the consumers. There's no real information on how many times a high or a maximum amount was charged in a hospital system, only that there was a charge and that there's some range of fees associated with that. So next slide.
And then in terms of advance notice for patients, what's required is that prior to the delivery of the non-emergent services, a provider-based clinic charges a fee, should provide a notice to any patient that it's going to receive a separate charge or billing for the facility component, which may result in a higher out-of-pocket cost. And then they must post in a notable area where it's easily accessible and visible to patients about those fees. And then these are the ones required to do this are those provider-based clinics site of it. And those are those that are off campus or in a provider office that is owned by the hospital or health system. Next slide.
So back to me, I think.
Yep.
Much like, so the next slide here shows what's not required. So while there is advance notice, as Janine talked about, it does not include notices provided to consumers by all clinics. So you're exempt if you provide labs, x-rays, testing, therapy, pharmacy, or educational services, or if services are designated as being provided by rural health clinics. Also, what's not included are ambulatory surgical centers or other providers unaffiliated with hospitals or health systems. There is not a requirement for notice before appointments, which could provide additional or result in additional complications when providers charge cancellation fees. Some states require at the time of scheduling or that consumers must receive an estimate in advance of scheduling visits what the facility fees are, which in our state we do not require. So next slide. Yeah,
and these are just some references for where this was pulled from. So I think with that, we are going to move on to our panel, unless there are questions at this point about that information.
And I see Eileen's hand is up. Go ahead, Eileen.
Well, I'm a little dumbfounded about this. I thought that the facility fees could only be charged by someone associated with the hospital. So what your study now is showing is that like doctors and the ambulatory surgical centers that are totally freestanding are actually also charging facility fees. I got that right?
I think the idea is that we don't know.
We don't know.
Oh.
Yeah. If they're not reporting, there's not a means for them to be reporting to the state to know for sure if there is a facility fee associated with the charges, say in an ambulatory surgical center.
And do either one of you know? I can't remember what year. It's been probably 10 years since we passed the original legislation about facility fees. I remember whose bill it is.
Yeah, I'm not sure I remember the year off the top of my head.
It's been a while. I know that.
And Eileen, some of our panel members might be able to answer with more specificity your first part of that question.
Okay.
And I'm just counting I'm watching the clock till Jane Beyer produces the year.
Well, actually, one of our national panel members has. It was 2012.
2012. Let's see.
Christine.
You should give prizes for those kind of health policy nerdy things. But other questions from board members? I am not seeing any hands go up. So thank you, Janine and Bianca, for level setting us. And it'll give us more time for the next part of this. So I would like to welcome our facility fee panelists, Zach Cooper from Yale, Christine Monahan from the Center on Health Insurance Reform, Suzanne Beitel, the Senior VP and CFO of Seattle Children's, April Lynn, the COO of Proliant Surgeons and a member of the Health Benefit Exchange Board, and Daryl Wolf, the CEO of Olympic Medical. And I think we'll begin with Zach, and then we'll move to Christine, and then we'll let other...
Yeah, I think we were going to break Sue for questions for those two since they're on the East Coast, so we could let them go and then turn to the other three after that.
Great.
So I don't know, Christine or Zach, which one did you guys
want? I'm happy to dive in. Can everybody hear me? Just give me a thumbs up. Awesome. Okay, good. I'm going to talk really briefly and hopefully leave more time for questions. I want to take a step back. There's been an amazing amount of work over the last 2 decades to expand insurance coverage. And so I think what sort of happened is we've shifted from primarily having to be focused on giving more folks coverage to thinking about healthcare cost issues. And right now, the average person is really fundamentally struggling to afford care. And that in turn is really creating this access issue. And so as prices and spending are going up, right, this is making accessing care much more difficult. And I think the reality that we've got to confront is that there just aren't really silver bullets for addressing costs in the US healthcare system. My own sense, my own belief is that in a sense, what we have to think about is just incremental steps. So I have a project called the 1% Steps for Health Reform, which outlines 18 of them. And, I think what we want to sort of do is say, look, what are I'm going to call them dumb things that raise spending without generating value for consumers? And how do we sort of play whack-a-mole, right? Nobody wrote country music songs about incrementalism, but it's sort of this type of incrementalism that I think is actually really where we're going to make progress. And from my perspective, facility fees are really one of those, again, I'll call them sort of dumb things that we need to fix. And so sort of how did we get here? If you went back 20 or 30 years, you had professional claims for physicians, you had facility fees for hospitals. If I went to a hospital to get an operation, a hip replacement, I was going to see, if I looked at the claims data, a facility fee or a facility claim for my hospital and a physician fee, a professional claim for my surgeon. If I went and saw a doctor in a freestanding facility, I was going to get a professional claim from that physician. Fast forward, and we're in a world with vertical integration between hospitals and physicians. We see some big changes in how the Medicare program pays. And we've really gotten to this space where I think a patient, really at no fault of their own, ends up seeing a doctor in a facility that looks a whole lot like a doctor's office and ends up getting a hospital bill and going, what in the world just happened? And this is really where the sort of whole brouhaha around site neutral billing has come from. And so I think we first have to say, look, I think the genesis for a lot of this comes from the lack of site neutral billing in the Medicare program. I think we're in a world where that lack of site neutral billing has led to a whole lot more vertical integration than we otherwise would have seen. And we're in a space where for things like infusions, things like standard office visits, I'm paying twice as much, or a carrier Medicare program, in fact, is paying twice as much for somebody if they're in a hospital-owned practice versus a freestanding facility. So, what's the problem? Why should we be concerned? I think there's broadly sort of three issues. The first is obviously that it mechanically is going to raise spending on the Medicare program, right? That's just sort of statutorily built in. The real challenge is that because private insurers follow the Medicare fee schedule, this is also going to raise commercial spending. As I said, it's going to confuse patients, right? This is, I think, not strictly what we think of as a surprise medical bill, but it certainly is a surprise to patients. Then we can think about the second order effects, which I think in many ways are more subtle, but potentially more pernicious. The first is when there's such a gap between the payment rate for a hospital-based physician or hospital-owned physician and a physician in a freestanding facility, it creates a strong incentive to nudge patients to be into those vertically integrated facilities, right? They're just the direction of travel is to push them there. Moreover, what it does is it encourages vertical integration, right? When a physician is going to make nominally double for the same thing in a hospital-owned practice, it just isn't in that physician's best interest to not be in a vertically integrated practice. And when they join a vertically integrated practice, in addition to the mechanical increases in spending, it creates additional bargaining leverage for both the hospital and the insurer. I think there's a metaphor that I often use to describe this. So my local coffee shop in Guilford, Connecticut, where I am, is called Cilantro's. It's a cute little sort of mom and pop coffee shop. And you can sort of imagine that, we'll call it American Hospital Association Coffee comes in and buys up Cilantro's. They're going to, keep the beans the same. They're going to keep the baristas the same. The facility is going to stay the same, but it's really changing the sort of ownership structure and the shingle that's out front. And because of the new designation, right, they can charge nominally double what they were charging before by tacking on a facility fee, right? The same cup of coffee, same beans, double the price. And that's basically, I think, what we're seeing with facility fees right now. It's happening at the state level through some of the policy choices. It's happening at the federal level. So, what do we do? And, I think here we've got to start with the obvious, right? Hospitals are different than physician practices. They provide different services. Their costs are going to be higher. And we've got to make sure that they're adequately compensated. I think we cannot take on that issue or this issue without adequately sort of acknowledging that. So what does that mean? I think we have to pay hospitals more when the services they're offering are different than what's getting offered in a physician office. I think particularly when it comes to rural hospitals, the challenging issue, we've got an obligation in certain circumstances to help rural hospitals stay open when they don't have adequate volume. But that doesn't mean that I think we have to give every hospital, or every physician-owned practice owned by a hospital a facility fee. What I think you often hear from hospitals is that if you go after facility fees, you're going to see hospital closures, right? So let's sort of take that head on. There are hospitals we've got to keep open, but the way to do that is offering very, very specific subsidies for those hospitals. It isn't giving every doctor's practice across the state additional money to keep a very specific group of hospitals financially solvent. I think you often hear hospitals say, look, they're going to face higher costs for providing care. And that's true, right? Like costs for operating a hospital are generally higher, but it turns out an infusion is an infusion is an infusion. And 70% of infusions are given in doctor's practices. And what we shouldn't be doing is paying more for the same thing when the cost for that individual service doesn't vary. Right. And the third is often there's discussion about safety standards. Right. And again, for a lot of the services where I think there are genuine proposals to, and I think Christine will talk more about this, genuine proposals to really think about how you'd roll back or address facility fees, those services are generally majority provided in non-vertically integrated physician practices. They're provided outside of hospitals. And it's pretty clear that you can provide them safely in that setting. So let's just sort of take a second to talk what we can do, and then I think we'll zoom back out and talk about what states are potentially going to do. There is a need at the federal level to introduce a site-neutral change to the Medicare fee schedule. Congress, the House, has passed different parts of legislation designed to do that. We'll see if the Senate takes it up. I think they will at some point. I think there are states that are taking really tangible action, right? My own state, the Nutmeg State, we've done some pretty cool stuff here. We've seen other states really be aggressive on things like telehealth, and it's worth taking a look. I think at a minimum, what we need to do is make sure that the claims data that we're seeing allows analysts, allows policymakers, allows everyone to really determine where care is getting provided. And that's something that's really, really hard now to do. Right. So whether a vertically integrated physician is operating in an HOPD, in a freestanding clinic, in a hospital itself. So to sort of wrap up before I hand it over, look, I think this is one of those low-hanging fruit issues that's pretty costly for patients. I think it's, from a policy perspective, pretty straightforward to fix. There are states that have done it, and now I think what we'll do is transfer over to Christine and hear about what some of those states' actions have looked like.
Thank you, Zach. Christine, over to you, and then we'll open it up for questions.
Great. Thank you so much. So as introduced, my name is Christine Monahan. I'm an assistant research professor at Georgetown Center on Health Insurance Reforms, which is part of the McCourt School of Public Policy. And thank you all for having me and accommodating my schedule. I would really love to listen into the rest of the conversation today, and I plan to watch the recording of it. But my husband, as you might hear in the background, is wrangling our two kids right now, and so I'll need to hop off after our Q&A to help get them into bed and fed. If we can put up my slides, great. Great. If we go just to the next one first, and really quickly, just if you're not familiar with CHEER, our team is composed of nationally recognized experts on health insurance and health reform with the shared mission of improving consumer access to affordable and adequate health insurance. Among other activities, we regularly work with state and federal policymakers to help them better understand the issues that they're working on and craft reforms. So please reach out if you are ever looking for technical assistance. On to the next slide. With the support of West Health, I and my team have been digging into outpatient facility fee billing reforms for nearly 2 years now. And I'm here today to talk to you about what can be done to reform facility fee billing. And I'd like to start by parsing out kind of the different goals that you as state policymakers might have in mind. And I think Zach really outlined kind of the big picture goals and issues we want to address, and that kind of is reflected here too, but also kind of call it a little bit more granular issues to tackle. So one concern you might want to prioritize is protecting consumers from out-of-pocket costs that can come with facility fee billing. So that has been explained already. When a consumer goes to a freestanding independent practice for routine services, they and their insurance plan generally just get that single bill from a clinician. When they go to the hospital and facility, they'll still get that professional bill, but they'll also get an extra separate bill from the hospital, the facility fee. And this can expose consumers to extra out-of-pocket costs in a couple different ways. First, with the growing number of consumers enrolled in plans with deductibles and those deductible levels increasing, many consumers will be covering the full cost of that added facility fee themselves. Second, that trip to an independent doctor's office with its single bill would have generated just one cost-sharing obligation, and while insurance designs vary, more often than not, this would be a copay. But if the consumer is going to a hospital-based setting and gets a facility fee, they may now not only owe that copay on their doctor's bill, but they'll also owe cost-sharing obligation on the facility fee. And more likely than not, that's going to be a co-insurance charge. So some of the options I'm going to talk about in a bit are primarily focused on reducing this consumer out-of-pocket cost exposure, which can make getting healthcare really unaffordable for people, especially as facility fee billing becomes more prevalent as more and more hospitals own outpatient settings. Another goal you may have, and that obviously is of great interest here, is reducing that overall spending. Greater spending in the commercial sector means higher premiums for patients and employers, as well as greater tax expenditures for the government. Tackling this, as all of you have experienced, is a lot harder, but I'll talk about some of the strategies that might be able to help. And finally, you might want to tackle the opacity around facility fees. Today, just as that first presentation really emphasized, we can see the big picture story of why facility fee billing can be problematic, but it can actually be really surprisingly difficult to discern the extent of facility fee billing, where people are getting care, who owns the different care settings, from the existing data sources, including healthcare claims. But there are several steps that states are starting to take to shed light on these topics. And so on the right of my slide, you can see the possible reforms that my team has been tracking. And there's also a link to a cheat sheet that we've made that evaluates how well each of these reforms performs against the issues we've identified. And so they include site-neutral payments, facility fee billing prohibitions, public reporting requirements, cost sharing protections, and consumer notification requirements. We go to the next slide. So with the help of West Health, we've spent this spring digging into state statutes across the country and seeking to identify any existing state laws that fell into one of these categories that I just mentioned. So as you can see in the map, we found that 20 states nationwide have adopted at least one type of reform. And these states represent a, oh, we have an echo.
I think if you're not speaking, if you can mute, please.
All right. So these states that have adopted reforms, they represent this broad political and geographic diversity. So, you can see that addressing facility fee billing is really a bipartisan issue. You can also see in the map, these different colors, they kind of reflect how many different types of reforms the state has adopted. So it's not necessarily that, you would just take one tackle from one issue. And yes, there are 6 different types, and they can be seen as alternatives, but actually they can all be kind of layered on top of each other to do a kind of address the issue more comprehensively, like Connecticut and some other states have done. And generally, this has been an iterative process for states. Just as Washington started this back in 2012, states will often kind of enact one reform in 1 year, different reform a year later, go back, expand, tinker. This is kind of a really slowly evolving process. So if you go to the next slide, I can run through these reform options one by one. So first, we have site-neutral payments. And this is where either a state sets a payment level for specific services to ensure consumers and insurers are paying the same price for the same service, regardless of the setting, or where the state requires insurers to make payments site-neutral while leaving the exact level up to negotiations. No state has enacted site-neutral requirements for the commercial sector yet, so we don't even have a map for this, but and we haven't actually even seen too many specific proposals introduced. There's been one, Senator Sanders floated a bill before the Senate Health Committee at the federal level. But I do expect that we're going to see some states putting forward legislation in 2025 that would introduce site neutral payments to the commercial sector. And this type of proposal has the biggest potential for impact of any of the reforms that we're discussing, although how much will depend on state design decisions, including whether and where to set that payment level, what services and settings are affected. You can do it really narrowly, or you can go broadly, or somewhere in the middle. And then whether you want to pair the site neutral requirement with a prohibition on facility fee billing, which can simplify billing and ensure that consumers' financial exposure is minimal. And I'll acknowledge site neutral might sound like a really big bite to chew off, but there are also ways that states can test it out much more narrowly. Say, you can have your state employee health plan move to site neutral payments, or you could maybe in Washington look at your Cascade Select plans or just qualified health plans and start to introduce it in a narrow portion of the market. The second reform we have up is banning facility fees for certain services or settings. And that's where a lot of states, as well as federal policymakers, are looking right now. The broadest formulation of this policy involves prohibiting facility fees for those services that can be safely and effectively delivered outside of a hospital setting. But states generally have started much more narrowly. For example, off-campus evaluation and management services, or even just things like telehealth or preventive services. And indeed, Washington has prohibited facility fee billing by hospitals for audio-only telemedicine services for several years now. And this type of reform comes with the benefit of protecting consumers from those out-of-pocket costs associated with the facility fee charge, since that separate second bill would go away. That said, the long-term impact on healthcare costs is likely going to be relatively small because you don't have a rate regulation component like you do with a site neutral policy. So this means that hospitals can potentially seek to recoup any loss of revenue by raising provider prices or facility fees in other areas when they go and renegotiate their contracts within a year or two of the policy going into effect. And so it'd really be up to the payers to constrain prices from going up. Nonetheless, as Zach kind of indicated, this prohibition could reduce some of the incentives for hospitals to acquire more outpatient practices, which could help save some money down the road. The third reform talked about is the billing and ownership transparency initiatives. And this includes things like a unique national provider identifier, or NPI, requirement, where off-campus hospital outpatient departments need to register for a location-specific identification number. Use that number on their claims so that payers and others, researchers and the like, can actually see the brick and mortar location where care is being provided. Now, to get the biggest benefit out of getting that information with your claims, you would kind of couple that with some sort of system to keep track of the NPIs, so you know which NPIs are affiliated with different hospital systems. And with this information, you could theoretically see payers try to rein in facility fee charges on their own a bit more effectively. But more definitively, you would provide policymakers like yourselves much better data to evaluate where and how much facility fee billing is happening and what sort of impacts reforms could have. And so currently 3 states have unique NPI requirements, and a 4th state, Maine, more generally requires that the location of care needs to be disclosed on claims forms. And while not represented in kind of the maps that we've made, multiple states like Colorado, Massachusetts are making progress in tracking provider ownership information as well. Then we have, and this has been discussed kind of in the first presentation a bit, is public reporting and other public oversight measures. And kind of what we report out on here, kind of the states you see listed, includes states that have created a commission or task force to collect data and study this issue, as well as states like Washington that have an annual reporting requirement. But as kind of the earlier presentation made clear, in Washington, that information is getting collected at such a kind of high aggregated level. It doesn't include on-campus clinics. And plus, my sense is hospital compliance might be a little bit spotty. And so that could be something where we have room for improvement. And I personally recommend reaching out to the state regulators in Connecticut who are collecting data at a bit more granular level and have been really tinkering with their reporting requirements over the past several years. And I think they probably have a lot of thoughts on both good and bad approaches that they've tried out. And then 5th up, we have cost sharing protections. And these are provisions that are designed to keep providers from balance billing patients for certain facility fees or limiting patients' cost sharing. So as you can see, they're not that common. Just Colorado and Connecticut have this in statute. And I think part of the concern is if you just approach facility fee billing solely as an insurance issue, you're not going to reduce overall spending, and you might actually exacerbate facility fee billing as we protect consumers from any exposure to it. Excuse me. That said, I think there are some more states that may have taken action here on a executive branch administrative side. Rhode Island, for example, has imposed some balanced billing protections for facility fees through their network adequacy requirements. So that's another angle that you could consider. Finally, we have consumer notification requirements. And with this, we're talking about measures where you need to send a letter or email directly to a consumer, tell them on the phone, or post a physical sign or notice on your website facility fee may be charged. As already was discussed, Washington has some provisions along these lines already. And these, as you can see, they're relatively popular reforms. You know, but, and, you know, and I think that's because like any facility fee reform is going to be met by robust opposition in the legislature. And I think it's pretty common to see a broader bill that might have originally prohibited facility fees get narrowed down to a notification requirement. And I think there are pluses and minuses to these measures. On the one hand, I personally would, prefer to know in advance if I were about to get a big facility fee bill and want that disclosure. But I'm a relatively sophisticated and financially stable healthcare consumer. For a lot of people, these notices might be really confusing, especially, you have your doctor saying this big bill could apply, but it's not necessarily clear what your insurance is going to cover. And these, warnings might deter some patients from getting needed care because they worry that they're not going to be able to afford this large amount that they may or may not end up being billed for. And, a lot of consumers may just simply not see or read the notice. So, I think that likely has a pretty limited impact. And so with that, I'm going to stop. But if you skim through, if you have my slide deck, you go into the appendix, you can see more of the maps that we've made that break down variations and how different states have enacted each of these reforms. And then there's a link on our website too, and then you can actually go to it. And if you click on any state on our maps there, you'll actually be able to see a summary of the law and a citation to it. So you can kind of get a lot more detail there. And so thank you so much for your time. I'm happy to take any questions.
Ingrid has her hand up.
Yes, I think Jane's was up first. Jane?
Yeah, thanks, Ingrid. So, Zach and Christine, great to see both of you. For those of you who weren't around in 2012, the legislation that we have started out as a prohibition on facility fees and got negotiated back to what is current law. So, Christine, you were spot on that comment. I have two different things that I wanted to talk about. Rather than relying on facilities to do the reporting on facility fees, I know we've been looking at whether there's any way within our all payer claims database we can figure out a clean way to determine where facility fees are being charged on claims, and it's been very challenging. So has there been work on, for example, where data submission guides for all payer claims databases can be modified so that we can get it from the source of the actual claim rather than having to rely on providers reporting? And then relatedly, would something like that be best paired with ownership reporting, a la Massachusetts? We do not have ownership reporting in Washington state, so we don't know which hospital owns which provider practice. So what are your thoughts on sort of those two strategies sort of combined or separate?
I'd say of the states I've spoken with, I just hear constant frustration about the ability to discern this information. And that's where most states are turning to an NPI-like requirement to be able to, at least first identify where the care is being provided. That one variation of that is kind of Maine's approach, and what I think they might be considering doing there, but they're still kind of tinkering with it, but is kind of trying to figure out, can we, instead of having a unique NPI, maybe we have some sort of addendum kind of code that providers would submit to kind of identify where care is. So then the NPI might kind of tell you the system level, and then there's some sort of separate billing code that they would add in on all of their claims forms. And so I think they're doing that, like working with the APCD to figure out, okay, can we, get these location specific codes added? So that might be one option, kind of along the lines of data submission guides to try. But I do think you do really want to pair, some sort of location specific identifier number with a way to track the systems. Colorado was the first state to do this unique NPI requirement, and they just had an NPI requirement with no system data. And basically they found out, okay, well, now we just have the reverse problem. We have all of this, we know the different, locations, but we have no idea how they're interrelated to each other and who owns what. And so, yeah, I think you really want to try to address this issue comprehensively from both angles.
Agree 100%.
Ingrid? Jane, did you have any additional?
I'm sorry. No, I'm feverishly taking notes. Thank you, Zach. Thank you, Christine.
Dr. Birch, okay if I jump in?
Yeah, I'm sorry, Ingrid, I was muted. I had myself muted. Go ahead, Ingrid.
No worries. Thank you so much for these presentations. It's so helpful to see this in a national frame. I'm Ingrid Ulrey, CEO of the Health Benefit Exchange here in Washington State. Also appreciate the mention of Cascade Care and the opportunity to sort of model this in a small slice of the market, such as the individual market. I'm curious, two things, just asking if you could underscore a couple of things. One is really, what do you see as the limitations of a state taking approach that's just really about transparency and data collection? And just thinking about like real people when they are referred by their doctor to go get a procedure, and the likelihood of them seeing a sign on the wall or small print notice, and the sort of the helpfulness of that alone, and what are the limitations? And two is just how do we as state level folks align to the effort happening in Congress, focusing on site-specific payment in the Medicare program? How do we leverage that? I said we're not just going to wait for them to fix it at the federal level, but how can we leverage that focus and attention, even though they're different words? It's really about the same problem. Thank you.
Yeah. So I think it's a great question. I think there are real limits to transparency. And I think you sort of alluded to why, which is for lots of really good reasons. When patients go to a provider, they take the advice of their physician and about where to receive care. And I think the challenge in economics, you'd say that maybe is a potential principal agent problem, right? The challenge here is when your physician is vertically integrated, right? They may have strong incentives to steer you to the system where they're owned. Likewise, I think it's just very, very hard to expect the patient to process all of that information at the same time. So I think I'd really temper expectations about what transparency could do. We see that certainly from the literature on price transparency. I think vis-a-vis site neutral billing at a federal level, my guess is it's going to be pretty constrained if we see anything get passed. And so the big bills that I think are most likely to get through right now are really focused on infusions. And so I think there's a lot of scope for piggybacking off of that and saying, okay, we can do them for infusions. We also probably going to have to expand them for other services. And then I think clearly it's protecting patients from we'll call these sort of surprise bill 2.0s.
I'd add on your first question, totally agree with Zach on kind of the transparency vis-a-vis consumers go. I think same reasons to be skeptical of that. As far as transparency in terms of kind of the claims data and information, I think there's real benefit to policymakers in particular to better understand what is happening and target their reforms accordingly. Also bringing transparency to claims, does potentially enable, private payers themselves to try to negotiate better deals and change their reimbursement practices. That said, I would not necessarily assume that they will. There are a lot of different incentives at play, and whether they would actually leverage that information, we'll see. But at the very least, I think it enables policymakers to do a lot. On the federal approach, one of the few tiny pieces that might move for the commercial sector is a unique NPI requirement. I think that's one of the things that's kind of made it into some of these bills so far. And again, there's bipartisan interest in some sort of greater claims transparency. And so I think kind of being at the forefront of that and kind of seeing where that's going and trying to align could be really helpful. The other thing, if you are thinking more aggressively and about prohibiting facility fee billing or about moving to site neutral services, while it has not been enacted, MedPAC has done a lot of really, really great thinking on this. The Medicare Payment Advisory Council, including, they've gone through and identified, based on kind of Medicare data, where are people getting care, and identified, okay, for these service codes, these can be safely and effectively provided in an independent setting, right? So that gives you a starting place where if you want to think about where do we want to prohibit facility fees, look at that list of services that MedPAC has made, and that gives you a really good start.
Thank you. Bianca.
Yeah, thank you so much for this presentation. Good to see you, Zach, and nice to hear your presentation, Christine. I'm at University of Washington, a professor in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. I'm curious, I was just looking through some of your appendix material, Christine, and there's something about outpatient reform, and I'm sorry that if I might have missed this, but it seems like there's a potential implication there that maybe there's some states that prevent maybe patients themselves from having to pay the facility fee, and then the insurance companies and the providers themselves can probably negotiate that, where basically it sounds like the insurance plan is being encouraged to cover the facility fee. Can you say a little bit more about those avenues? Because that's an interesting model where maybe it's really a negotiation between the insurer and the providers as to who should actually pay for it, but ultimately maybe it's just not the consumer themselves who should pay for it. Can you talk about that and how that's been discussed?
Yeah, I think the cost sharing protections have been kind of the least pursued of what we looked at. That said, Connecticut kind of says that insurers can't impose a separate co-payment on facility fees for outpatient services that are provided at an off-campus location. They also have some limits on when limiting providers from balance billing consumers for facility fees. And Colorado also says that, providers can't balance bill for facility fees for preventive services that are provided in outpatient settings. So these are pretty narrow protections. And, and we had kind of asked about this topic in a set of interviews that we did back in 2023. And there were, I think, hesitations over kind of taking this insurer-only approach just because it could, it just encourage more facility fee billing, right? One of the reasons that, frankly, this is getting policy attention is because there are a lot of news stories right now about consumers getting these bills, and there's a lot of outrage over it, right? So there's kind of the pressure to maybe do less of it because consumers are facing it. And, admittedly, from the insurer perspective, they're theoretically trying to lower costs. And one way to do that is to direct consumers towards higher value, lower cost settings of care. And a common means of doing that is adjusting the cost sharing to, have patients pay more when they go to a higher cost setting. So I can kind of understand why insurers are kind of using these tools, but from a consumer perspective, it's really problematic. So it's kind of a complicated way to go to, it's a complicated issue. And I think there are kind of arguments on both sides of, whether or not to allow consumer cost sharing and how much to allow. I had another thought, but it is now briefly escaping my memory.
I think
just in terms of, sorry, just
really,
gonna add,
yeah.
just one more thing, is just in terms of like negotiations, what we have also seen is having in Massachusetts, there was big outrage. There were a lot of news reports about facility fee billing. The insurers and providers in the state largely actually negotiated to protect consumers by limiting facility fee billing, right? What they did, they didn't say, okay, we're going to, impose some cost sharing protections. The insurers and providers came together and said, we're going to eliminate that facility fee bill for routine medical services, right? And that's how you kind of get at the actual issue. You protect consumers by not having that second bill in the first place.
Thank you, Christine. That could be a really great future panel discussion where we have them come in and see if they could talk to the board and do something voluntarily. But Zach, did you want to add something?
I do, and I think we can maybe stop sharing the screen. I can't really see people, but I think it's worth saying, if we step back, cost sharing isn't the only way that consumers pay, right? I think there's this sort of easy way to think about it, which is, oh gosh, when health spending goes up, it's a cost on the insurers. No. We actually know this really, really clearly. It's paid for by workers, right? So we actually have some work on this out a couple of weeks ago, which shows that there's largely dollar for dollar pass through of rising health spending to workers themselves, right? And how do workers pay for rising healthcare costs? They actually do it with their jobs. And more than just losing their job, it's actually inequitable because it tends to be workers for various reasons earning between $20,000 and $100,000 who are the ones who experience labor market separation. And so when health spending goes up, right, it certainly increases out-of-pocket costs, but most care, at least hospital-based care, is covered by insurance. And so who's paying for it? It's workers. So I think the real risk for insulating consumers against out-of-pocket costs is that it does two things. It actually increases aggregate spending. And then ultimately that leads to the patients themselves, the consumers as a whole, paying more and increasing inequality, right? It's sort of, in many ways, the worst of all worlds.
Appreciate that perspective and reminder. Thanks, Zach.
All right. I think I want to thank Christine and Zach for giving us your East Coast time. And Christine, I know we got to release you to your two kiddos. And we want to move on to our panel in the interest of time. I know we can reach out to both of you, but thank you both so much for a very informative presentation.
Thanks so much for having us.
And let me know. I'm happy to stay for the second one if you want me to, or I'm happy to transition off.
It'd be great if you want to continue to be with us. That'd be great.
Yep.
All right. So we have several Washington providers. We've got Suzanne Vitale, April Lynn, and Daryl Wolf. And I'm going to turn it over to who's going to start first for a few comments, and then we'll do question and answers with them as well.
I think I am up first. Suzanne Vitale here.
Great. Welcome.
All right. Well, we'll get started. I want to first thank you very much for the opportunity to listen in to the earlier conversation and provide comments today. As you said, my name is Suzanne Vitale. I'm the Senior Vice President and Chief Financial Officer here at Seattle Children's. And proudly, our outreach programs cover nearly 1 million square miles, which is, and many of you may know this, the largest service area based on landmass of any children's hospital in the country. Seattle Children's has its main hospital campus in Seattle, and we serve patients in our regional hospital-based clinics in locations such as Federal Way, Everett, and Bellevue. At these clinics, we provide complex diagnostic and therapeutic services to children, all children, regardless of their ability to pay. And in fact, in 2023, we provided $360 million of under and uncompensated care to children in our communities. All of these clinics were additions to the communities in which they are located. They were not clinics that were acquired by the hospital and converted to a hospital-based. At these sites, we provide sedated imaging to toddlers. We infuse strong medications to adolescents. We do surgeries. We open these clinics to improve access, to be more convenient to families, especially those families that are socioeconomically disadvantaged. These clinics would not have been opened if hospital services provided could not have been reimbursed like a hospital, and these services cannot be sustained unless we are reimbursed like a hospital. At these clinics, 49% of our patients are Black, Indigenous, or people of color. 76 languages are spoken. More than 55% of Seattle Children's patients are covered by Medicaid. In 2023, Seattle Children's saw nearly 400,000 patient visits. Over 40% of those were in a clinic setting. Quite simply, we are working incredibly hard to deliver care closer to home for our kids in our communities. We also operate 2 primary care clinics, neither of which are hospital-based. Zach talked about the origin of the healthcare system and the billing system and the billing methodologies, one which was designed for hospitals and another for physician offices. So I just want to comment on that and pick up a bit as well. So these are two entirely different payment methodologies, and they're aligned with the services they provide. So hospital billing includes facility fees to cover the staff, technology, equipment, all necessary to provide intensive healthcare services. And over the years, more and more intense and complex services have moved to an outpatient setting. As such, the cost of those services needs to be accounted for. Today, when a patient comes to a hospital-based outpatient department or clinic, their insurer does receive two bills, one for the outpatient department or clinic, called the facility fee, and one for professional services. Facility fees are not an upcharge. They cover the operational costs associated with supplies, equipment, building needs. They also cover the cost of meeting the regulatory requirements from a state and federal perspective. So we seem to have a perception out there, and I think it is pervasive, so I want to comment and speak to it, that not-for-profit hospitals are in fact highly profitable. However, the truth of the matter is our organization, Seattle Children's, has experienced significant operating volatility since 2020, clearly since COVID. And two out of the last 4 fiscal years, 2 of those years we operated at a loss, including last year where we lost $30 million. That's not sustainable. That's not the healthcare system for kids across this massive geography that we want. So while we're a not-for-profit, and we acknowledge that from a tax perspective, we do need to be good financial stewards, and we need to generate a margin. And we need a margin to enable investments in our communities, in our services, our facilities, our staff. Our overarching goal is to provide high-quality, accessible healthcare to all children in the service area. And so the headwinds on doing that, Medicaid pays about 65% of the cost of providing hospital care. So cutting facility fees would amount to a reduction in payments for important children's healthcare services. Yes, we have updated the safety net assessment program, referred to as SNAP in the state, which is funded by a voluntary assessment paid by hospitals, and we will draw down more federal match. And that will increase Medicaid rates to about 85% of a hospital's cost. And the SNAP increase does not cover professional fees at all. So nationwide and in Washington, we've seen physician groups actually being forced to limit services to patients covered by Medicaid or public insurance programs because the payment rates are simply not adequate. And then oftentimes hospitals like Seattle Children's are the only organizations that are able to provide such outpatient services. So without facility fees, Seattle Children's and other hospitals would have to make really tough decisions about discontinuing certain services at regional clinics. That puts a huge burden on families. We all have the experience of hearing families that have to traverse mountain ranges, bodies of water to get to to get access to our providers, our care. That's not the model. That's not best for our patients, our families. That's not best for our state. While facility fees make a small percentage of total cost of care, the impact to access would be significant if they were eliminated. And I just I started with a comment about being proud of the landmass and the geography that we cover. I'm also incredibly proud of the fact that we did not send one patient to a collection agency for an unbilled facility fee last year or any year in any recent history. And our charity care policy exceeds state requirements. I mentioned already the millions, hundreds of millions of under and uncompensated care that's provided. So I appreciate the conversation. I think it's incredibly illuminating. However, I would just close with urging the board to consider the impact on access to quality, and I underscore quality, specialized care, and engage in a really thoughtful cost-benefit analysis before endorsing any cuts to healthcare services in Washington State.
Thank you, Suzanne. Who's going to be up next? April or Daryl?
I think it's me on the agenda. Thank you, Daryl.
Go ahead, April.
I think, do you have my slides? Thank
Yes.
you. Thank you. I appreciate that. I'm a very visual person, and while I do not approve of death by PowerPoint, I put together just a few slides to try and give us a visual representation of what I'm going to talk about today. First and foremost, I really appreciate the opportunity to talk with you. I hope that today's conversation will bring about some mutual understanding of the differences in the use of the term facility fee. But before I talk about that, let me just tell you a little bit about ProLiant Surgeons. As Director Birch said earlier, I'm April, and I'm the COO of ProLiant Surgeons. ProLiant Surgeons is an independently owned physician organization of about 170 shareholders. We have about 350 providers throughout the western side of the state. We have clinics as far north as Bellingham and as far south as Tacoma. We have about 100 different locations, providing 800,000 outpatient visits and about 65,000 surgeries every year to the residents of the greater Puget Sound area. About 68% of those 65,000 surgeries are performed in our 14 ambulatory surgery centers. So having the opportunity to talk to you about what facility fees mean to an organization like ProLiant Surgeons is very near and dear to my heart. So Mandy, you can flip to the next slide. Thank you. So the differences in the term facility fees, as we've sort of heard talked about today, there's two different ways that we charge facility fees. The first is on the left-hand side of your screen, which is a non-physician owned place of service, which is typically a hospital or a large healthcare system. And they charge facility fees in addition to the fees that they charge for the actual visit. And they're often charged at clinics that are owned by hospitals to cover the cost of maintaining the facility. And fees range anywhere from $15 to hundreds of dollars, depending on the service that's received. And that, I believe, is specifically what we've been talking about in earlier discussions today. I think Suzanne alluded to what is on the right-hand side of your screen, which is what we call in our 14 ambulatory surgery centers a facility fee. And what that does is it pays for the cost of delivering that surgery to the patient. Without the facility fee on the ambulatory surgery center side, we would simply not exist as an organization or as an industry, not just as an organization, but as an industry. The facility fee is the payment for services for the use of that ASC, things like the building, the staff, the supplies related to the surgery and or the procedure. And ASCs are typically owned and operated by independent physicians. Some may be joint ventures with hospital entities. We have one of those entities in our ProLiant system at Valley Medical Center. And typically the hospitals in a JV situation will own less than 50% of the surgery center. You can flip to the next slide, Mandy. And then I pulled the RCW code because it's a bit confusing. I got to this meeting via Jeb Shepard at the Washington State Medical Association, and he brought this to my attention that there's some gray area that could be interpreted in what we're calling a provider-based clinic. And when I read this, I think that a provider-based clinic that's charging a facility fee is a hospital-owned entity. But if you read through this WAC or this RCW, and I will not do that for you today, I put a link on the slide, there's a gray area in it. And so I want to make sure that any future legislation recognizes the fact that delivery of an ambulatory surgery center service is fully and solely dependent on the facility fees that were paid from Medicare, Medicaid, and our commercial insurers. Next slide, Mandy. And then Suzanne also alluded to this. There are two components for billing a surgical procedure, and I'll only speak to an ASC. I've never worked for a hospital system before, so I don't know what their billing looks like. But there's a professional service, and what that professional service covers is the actual work that the physician does in performing the surgery. There are also assistants at surgery that are paid, people like physician assistants, ARNPs, and RNFAs. In an outpatient independent physician practice, these charges are billed by the clinic and on the clinic side. And then there's the facility bill, and that covers the cost of providing the service. Again, the operating room, the ASC staff, utilities, janitorial. And when performed in an ASC setting, these particular charges are billed by the ASC itself. Next slide, Mandy. And then just to point out, my next two slides are about cost of care delivery and then reimbursement. And when you talk about cost of care delivery, I think Zach and I apologize, I forget the other speaker's name, alluded to the fact that anytime you're having a procedure or service done in a hospital delivery system, the cost of care is significantly higher. Medical procedures can cost as much as 58% more at HOPDs when compared to a physician office or ASC setting. Colonoscopy screenings, 32% more. Diagnostic colonoscopies, 58% more. Cataract surgery, 56% more. And more than 50% of HOPD cardiovascular procedures could be allowed in ASCs for Medicare's covered procedure list inclusion. And then the average cost of a knee arthroscopy with simple cartilage removal at an ASC is $3,400 compared to $5,200 for that same service delivered in an HOPD. And these are very recent. This is very recent data that I've pulled from a very reliable source, which is Becker's ASC review. Next slide. Thank you, Mandy. And then Medicare reimbursement. If you look at the Medicare reimbursement for the ASC facility and physician fee compared to the HOP, the same procedure done in an HOP facility and physician fee, you can see there's a significant difference. ASCs are paid significantly less than what HOPDs are paid, and yet these procedures can be done very safely in an ASC setting. And again, when we're talking about costs, we need our hospital partners. We appreciate our hospital partners, but there also is room for ASCs to lower the cost of care, of overall care, when a patient who is, of course, patient selection is critical in an ASC setting. We want healthy patients who can have their procedures done safely in an ASC facility, and then again with the intent of saving the healthcare continuum significant amounts of money. And that's my presentation today. Does anyone have any questions?
April, I think what we'll do is move to the last presentation, and then we'll ask questions of the three of you.
Thank you, Director Birch.
Okay, Daryl, why don't you go ahead?
Yeah, hey, thanks everyone for having me. My name is Daryl Wolf. I'm the CEO at Olympic Medical Center. Olympic Medical Center, we're a public hospital district, so we're governed by a 7-member publicly elected board. We're a safety net hospital and designated as a sole community hospital and a rural referral center by CMS. We are the largest employer in Clallam County. We're located on the northwest corner of the state on top of the Olympic Peninsula. We are the largest employer here. We employ and buy health insurance coverage for about 1,550 people, and we cover a square area, not as big as Children's, but about 2,000 square miles here. So we serve residents on the North Olympic Peninsula at our main hospital, Olympic Medical Center here in Olympic Memorial Hospital here in Port Angeles. But we have clinics across our district. Our district runs from the eastern side of Clallam County all the way to Lake Crescent, if you're looking at a map. We provide primary care, walk-in clinic services, cancer care, gastroenterology, general surgery, neurology, women's health, orthopedics, pulmonary medicine, sleep medicine, and urology. across our district, primarily at our two campuses, one in Sequim, Washington, and one here in Port Angeles. As a public hospital district, we take everybody regardless of their ability to pay. Of our patients, over 60% are on Medicare, about 15% are on Medicaid, and 10% are on other government payment programs such as the TRICARE program. Only about 15% of our patients are on private or commercial insurance. Our public hospital district, we serve a population of around 67,000 people in the district, but we are, as I mentioned, a rural referral center. We serve the West End all the way out to the Pacific Coast. We serve a total population of about 79,000 people. In the 18 years I've been here, OMC has continually stepped up and taken on freestanding physician clinics that were no longer financially viable locally. It was not a profitable thing. This was done to maintain the local healthcare delivery system. And up until the pandemic, we've existed on a slim 2 to 3% margin. Having these clinics here increases access and allows patients to receive quality care near where they live. Not exactly where they live, but near where they live. Again, without OMC, these clinics would not exist. Healthcare payment rates are unsustainable for independent providers. The only clinics are either heavily subsidized, fairly qualified health centers or tribal clinics, or they're paid below cost like Olympic Medical Center's clinics. Access to primary and preventative care as well as chronic disease management are necessary tools to prevent unnecessary hospitalizations, which as a CEO I care a lot about in our constantly busy hospital. The reason the board is discussing facility fees is to potentially lower cost. I understand. But the loss of access to these local outpatient services would actually increase the cost of care because members of our community would not have access to care. Not only that, they would be traveling much further for the same level of care. The ability to be reimbursed for facilities fees has allowed us to create an oncology center in Sequim that sees thousands of patients per year, as an example. For a cardiology clinic in Sequim, the nearest one is over an hour away if the Hood Canal Bridge does not open on you. The same can be said for neurology and pulmonology. Some specialties such as urology can be found in Port Townsend. However, Port Townsend's facilities are a little smaller than ours, so different capabilities there. And again, I mentioned our cancer center services in Sequim, which I have a hard time imagining no cancer center in this area, given the intensity and the frequency of care here. And as the others have mentioned, especially Suzanne, OMC experienced a negative 7% margin in 2022. We lost $16 million, and we lost $26 million in 2023, which is a negative 11% margin. And like Suzanne mentioned, Medicare only pays us about 81% of the cost of care, and Medicaid is only 65%. However, that will be improved somewhat with the Medicaid SNAP program. The professional fee reimbursement alone does not necessarily cover all of the cost of salaries and benefits for the provider alone. So the facility fees that we do generate are a way to cover the gap in those costs, as well as others have mentioned, the cost to keep the clinics running and all the other expenses that come with that. As I've stated earlier, the only way OMC was able to keep the healthcare delivery system here intact over the last 18 years that I can speak to was having the ability to charge for some additional fees beyond just the professional fees. So the question was, well, what happens if these go away? It's difficult for us to remain competitive for the workforce that we need here. The clinics can't operate without necessary providers and staff. The only option for OMC would be to build more facilities within 250 yards of the hospital. That's counterintuitive to me as we try to serve the entire community. Eliminating facility fees does not come without a cost to the healthcare system, especially in rural areas like ours. So we joined the community in urging the board to consider the impact to access, engage in the actual cost benefit analysis of the loss of services in the rural part of our state before endorsing any policies that reduce this stuff. So I was trying to keep it quick. I know we want to get to questions, but I just think the challenges in rural are a bit different, and we're it. And so, in short, without the facility fees, I'm not sure how we would keep all those services here locally. thank you for your time, and I'm welcome to answer any questions.
Thank you to our panel presenters. I guess I'll start off with the first question. I'm wondering if the board were to delve deeper into the transparency piece, what sort of burden or hardship would that be to do increased reporting or accountability about your ownership lines, the way you price, and all the specificity related to facility fees? Is that doable, easily doable, so we can get that kind of transparency, or are you thinking that's going to cost a lot?
On the ProLiant side, it's very easy.
I guess
for that.
So. Sorry, just for clarification. So, as far as where the money goes, or I mean, as far as in the clinic, what are those dollars being spent on? Is that what you mean?
No, if we increased reporting on transparency details, like, getting very specific, getting a lot more nuanced. I'm just wondering what you would have to do, change in your systems to account for that, for greater accountability and transparency.
Right. I don't know. Again, I'm kind of far removed from being an expert in the EMR anymore, but I do think we want to be honest, and we have nothing to hide. Mining the data obviously takes time and resources. So I guess it depends on what you're looking for. I can tell you, I mean, I think we do look at our clinics from an accounting perspective, kind of as independent departments. We could pull in what the losses are per clinic, if that would be helpful. We don't make money in the clinic business necessarily as an organization. Like I said, we're just trying to survive. So, but I'm all for transparency. But I think depending on what you're looking for would depend on what resources it might take. So I know it's kind of a non-answer, but I'd be interested in knowing what you're looking for, and we could try to.
Daryl, oh, sorry, Sue, go ahead, please.
Daryl, one of the things that is kind of shocking to me is as we've infused an additional $2 billion into hospital rates from Medicaid, we continue to see commercial going up. So, for example, one of the things that I've been wondering about is how do we start on the commercial side, just putting downward pressure or capping things on the commercial side, saying there are going to be no facility fees in commercial. I'm just, because we have Medicare cost reports and whatnot, so I'm just curious, how that kind of accounting transparency and detail would play out for you all.
Yeah, well, I can speak a little bit about, we do a pretty intense DOH survey each year, which has a lot of statistical values and accounting, Medicaid cost report, Medicare cost report. I don't know if there's more detail that you're looking for beyond that. I haven't done those for a little while, but sorry, Suzanne, you had something to say. I cut you off.
No, I honestly, I was really tracking with you. I think that there is a desire to, again, have these conversations. I think when this panel opened, there was the word together. I wrote it down in my notes. Like we are all in this together 100%. And if there is information that is being sought, we'll endeavor to get it. But there are realities. I know in our organization, when we work to collaborate with our information technology and our data scientists, there just are there can be challenges. So it's hard to know. It's a little bit of an open-ended question. I'm sort of with Daryl, which is to say, what information are we looking for? We would look to solve it, or maybe we'd say, if we scope the problem statement adequately, then we can get the information that we think would shed some light on it. We know that our friends at the Washington State Hospital Association often ask for additional information, additional data. We work to address and build out a fulsome picture on data and information. So I think it was, provided we get more, so you get a little bit more specific on the information needed, then we would be happy to tell you what is the art of the possible, for sure.
So as the two of you go back to work with hca on this in partnership, I think a better way for me to have asked that would have been, how are your costs set for specific services? Mm-hmm. And who determines those costs and how are they set? And so, and why should we continue to perpetuate hospitals doing services that could be provided at facilities that don't charge fees, or, that we can get same value and quality for? So those are the things that I think this board has to continue to delve into and come up with solutions. Jane, I see your hand is up.
Yep, thank you. So, Suzanne, nobody's going to minimize the role that Children's plays, serving a million square miles and the tertiary services that are only available from Children. And Daryl, nobody is going to question the role that a rural Soul Community Hospital plays. So I think it's a little bit challenging to have a discussion broadly about facility fees when you are looking at it only through the lens of the predominant children's hospital in the region and only through the lens of a rural hospital. Because just like Zach was saying earlier, right, we know how critical Olympic is and the access that it provides to its communities. So I would suggest that if the board is going to dive deeper on this, as Sue indicated, we're diving deeper, not just with respect to specialty or rural community hospitals, but we're also looking at urban hospitals that aren't, specialized hospitals. Yeah. And April, question for you. I don't think anybody doubts the numbers about ambulatory surgery centers being less expensive than surgeries and things that are provided in hospitals. Quick question for you, though. When you think about facility fees, are we thinking about the fees that are associated with procedures or surgeries, or are we also thinking, like, does Proliance charge an additional fee when somebody's coming in after a surgery for an E&M, a follow-up that's billed as an E&M code?
No, well, it depends on whether they're in a global period or not. Every surgical procedure has a predetermined global surgical period. If the patient's in the global surgical period, the professional physician service that the physician billed covers typically up to 90 days of physician care post-surgery. That it does not cover things like x-rays, or if the patient needs an MRI, or if they have to be returned to the operating room or something along those lines. But if I go in and have shoulder surgery for 90 days, my care by my physician is typically covered in that fee that he has charged for his professional services. The facility fee is something totally different. The facility fee is separate from that.
And so if I come in for a follow-up, like you said, clearly if I need further surgical intervention, the facility fee is going to apply. What if I need imaging? Would facility fees apply to the imaging?
And thank you. So one of the things that I did not put on my slide is we do not charge facility fees in addition to visits or facility fees. Like when a patient comes into one of our clinics, we call them care centers. When a patient comes into one of our care centers, they're charged for the visit. There's no facility fee in addition to that visit.
Okay.
The only time a facility fee is charged, and I've been in several outpatient organizations. I don't know of any that I was involved with that charge an additional facility fee. Okay. That tends to be a hospital, a physician's office that's owned by a hospital. So at Proliance, there's no separate facility fee.
Okay, thank you. That's helpful clarification.
Questions?
Thanks for asking.
Other questions from board members? And Zach, feel free to jump in as well, since we still have our national expert with us. And I'm not sure, Greg, if you are interested with any thoughts you have about kind of commercial solutions or what you're experiencing at Boeing.
Can I ask Zach a question?
Yeah, go ahead, Daryl.
Hey, thanks for earlier, Zach, and I appreciated something that you said, and I wanted to know. You mentioned something about, if we didn't have facility fees and a lot, because a lot of these practices are now, owned or run by hospitals. You said something about you'd have to pay. I mean, so what other ideas would you have if those went away? And you're talking about maybe Medicare or CMS as far as do you know anything that's brewing out there? Sorry, I'm putting on my other hat for a second. That is looking at, because again, I mentioned we're 60+% Medicare here. And as we pointed out, it's 81 cents on the dollar, more or less. What other things have you seen the other things out there that are maybe things that are models that we might be able to look at as the only sole community provider and trying to figure out how to make that equation work?
Totally. So, I think it's a great question. I want to take the first part and then I'll answer that. And I do want to double click on the 81% of Medicare, because I think it's worth engaging with that too. I think there is discussion in DC as they think about site neutral billing on ways to say, okay, if there are real concerns for rural hospitals and we really do need to focus on these rural hospitals, what other programs could we put in parallel, right? And as I'm sure you're aware, right, there are sole community hospitals and critical access hospitals. There are a range of programs. And, I think at a federal level, one of the things to think about is if you're going to, you want to protect the hospitals that are really at risk of closure. And the way to do that isn't subsidizing Yale New Haven Hospital, right? It isn't giving Mass General more money in an effort to try to, get money to the hospitals that we think are really in these rural areas. So I think it's really efforts to say which rural hospitals are really vulnerable, and then how can we think about more efficient ways to support them without giving a whole lot of money to potentially hospitals that just really don't need it. I do think there is a challenge about talking about costs as a percentage of Medicare, and I know Suzanne talked about it. And, the challenge there is it sort of assumes that costs are sort of not determined by hospitals themselves. And so in general, what we see is most hospitals make money on the privately insured and often lose money on publicly insured patients and then talk about it. What you generally see is that the more the hospitals that see more publicly funded patients tend not to lose money on those patients. So a place like Montefiore Medical Center in New York, which is primarily seeing Medicaid patients, actually makes money on Medicare beneficiaries. And so I think it's worth sort of saying, are there ways that we could maybe get our cost structures in line so that, there is the ability to make margin on publicly reimbursed patients. And I think, Sue, you mentioned it. What we're sort of getting at a little bit is this idea of cost shifting, right? That private rates are high because public rates are low. And one of the ways we sort of potentially know that isn't a real phenomenon, I think, is that when Medicare and when Medicaid reimbursement rates go up, we actually don't see any slowdown in the growth in private rates. If anything, we actually see the private rates go up even more quickly. And so I think, that's sort of how I think about some of those cost structure issues.
Okay, thanks.
Mm-hmm.
All right. Well, I'm not seeing other hands going up. I know we will have more discussion in the future. I want to thank our panelists, and we need to move to our public comment period. So April, Daryl, Suzanne, thank you very much. More to come on this very important topic. And I'm also anxious to see what our federal partners and Congress do as well.
Thank you.
Thank you.
Thank you.
Okay. This is the part of our meeting that we designate for public comment period. A few things to remind everybody: written public comments received since our last meeting can be found under the 6 tab in your board materials. We allow individuals to sign up to provide public comments before the meeting, and we'll start with those that have signed up. If you've not signed up and would like to provide public comments, please raise your hand. Mandy's going to call on you after we hear from individuals who have signed up. When you are called upon, please state your name and affiliation, if any, before speaking. You're also welcome to provide comments in writing via email to the board at any time. And Mandy, with that, will you please start with the names of individuals, if any, who have signed up to provide comments?
Thank you. John Godfrey.
John, if you are speaking, we are not hearing you.
He is in this transition still.
Okay.
I think Zoom is still transitioning from what I can see.
And I'm assuming that is the board correspondence that has come in. It's really small print. Or is that additional new correspondence?
Sorry, no, that's correspondence that was already in the board packet.
Thank you. It's really tiny print.
Yeah, don't worry about that.
Okay, John, I see you on. If you'll come off mute, the floor is yours. If you'll identify yourself and your affiliation, please.
Good afternoon, members of the board. My name is John Godfrey. I'm a small business owner from Seattle and program manager for Washington Community Action Network. First, I'm here to express the deep frustration of small business owners on the excessive increases in healthcare costs. I'm in a minority of very small business owners who can afford this, and it just simply isn't right. But it's no surprise since the cost of premiums alone for my staff have gone up nearly 20% in each of the last 2 years. This is unacceptable and unsustainable. And I also wanted to comment a little bit today on facilities fees and the rampant consolidation that has gotten us here. But a lot of that was made irrelevant by Dr. Monahan's excellent presentation that I was planning on citing in these comments before I even saw the agenda. So thank you, Dr. Monahan. I'll just reinforce a couple of the comments from this conversation then. I strongly agree that solutions such as consumer notifications, reporting, and transparency are all limited in their impact. As we pursue such policies, I must reinforce Jane's point that ownership, transparency, and billing certainly need to be hand in hand to be effective in this discussion. And I also support banning facility fees where they are inappropriate for outpatient services. It's undeniable, as we've seen more and more consolidation over time, these facility fees are creeping into all kinds of places, including outpatient care. And finally, both of the issues I'm discussing today, the facility fees as well as the premium increases underline this board's mission to develop enforceable cost benchmarks for providers and insurers. Without transparency and accountability, our healthcare system will continue to be plagued by multiple challenges. Thank you so much for your time.
Ron, thank you for that input. We don't often hear from small business owners, so we really appreciate that you took the time to call in and share those comments with the board. Mandy, who's next?
Jeb Shepard.
Go ahead, Jeb. There you are.
Hello, good afternoon. My name is Jeb Shepard. I'm the Director of Policy at the Washington State Medical Association. We represent physicians in all specialties and practice settings across the state. I want to take you back in time to your retreat in last winter when you selected policy items for exploration and consideration for inclusion in your report to the legislature. While the board acknowledged the significant costs associated with wasteful administrative spending in the country, the decision was made to defer exploration of this issue to the Universal Healthcare Commission. And I'm pleased to share that they have dug into this at their June 4th meeting. Family physician Dr. Diana Huang and I shared challenges that physician practices face with administrative burden created by various compliance requirements. Those include the human impact in terms of physician burnout, moral injury, leading to workforce challenges, negative impacts on patient care, and germane to this board, the impact on the total cost of care. The main point we'd like the board to take from our presentation is that reducing the cost of healthcare without addressing the system in which wasteful administrative requirements and resulting costs are perpetuated will have a devastating effect on physician practices and patient access. We implore the board to account for this cost burden when making recommendations to the legislature, and would urge you to watch the June 4th recording of the Universal Healthcare Commission, where we're joined by a representative from Evergreen Treatment Services and the insurance carrier industry. Thank you so much.
Thank you for those comments, Jeb. And staff, maybe we can get a link posted to that hearing so it's easier for board members and the public to access.
I'd be happy to put that on the chat thread and include the webpage where that's located.
Great.
I have Leslie Bennett next.
Go ahead, Leslie. The floor is yours if you want to come on screen and unmute yourself.
Thank you. Good afternoon, Director Birch and board members. I'm Leslie Bennett of Northwest Health Law Advocates, a nonprofit that works to improve access to health care for all Washingtonians. NOLA and other members of the Fair Health Prices Washington effort appreciate the cost board's focus on the consumer impact of rising healthcare costs, such as medical debt and facility fees. Today, we joined with over 20 other organizations and community leaders to submit a letter to the board that details some of the many ways that Washingtonians are harmed by unmanaged health costs, including information from a forthcoming survey of over 1,000 Washington residents that found that 4 out of 10 surveyed households reported being charged a hospital facility fee. When we looked at facility fees reported for 2022, we found that more than $130 million were collected from Washington patients, with some as high as $3,800. Since facility fees are not always covered by insurance, this cost ends up being an out-of-pocket expense for many, and one that is impossibly high for some. In fact, when the survey found that 60% of Washingtonians either can't afford or would struggle to pay an unexpected $500 medical bill, and medical costs caused more than half to use up all or most of their savings, struggle to pay for food, heat, and housing, withdraw retirement or college funds, or reduce other spending. With that said, we recognize that facility fees are a symptom of our ailing healthcare system and not the cause. It's critical that the cost board continue its focus on the kind of bold systemic policy levers that can stabilize and drive down costs for Washingtonians while at the same time maintaining quality and access. And you can do that by first ensuring an actionable spending benchmark, second, engaging with price variation and related modeling, and third, delving into impacts from consolidation. As we enter the third straight year of high health insurance premiums with no relief in sight, Washingtonians are counting on the board to deliver the information we need to make a meaningful difference on healthcare costs, and we look forward to supporting your bold vision.
Thank you, Leslie. Mandy, who's next, please?
I have Mark Manti, and I apologize if I pronounced your last name incorrectly, Mark.
Go ahead, Mark. If you'll identify yourself and your affiliation, please.
Yeah, good afternoon, Director Birch and members of the board. My name is Mark Manti, and I serve as CEO of Vancouver Clinic. Vancouver Clinic is the state's largest multi-specialty group practice that, despite challenging trends in outpatient healthcare, still remains physician-owned and independent. We are now over 500 clinicians covering 2 states with a fully integrated ambulatory care system that includes primary care and specialty care, 2 ambulatory surgery centers, 8 urgent care locations, and a full complement of ancillary services. We serve over 230,000 patients, and our patient satisfaction rate is one of the highest in the country as a medical group. We also serve our entire community, including those on state Medicaid and our veterans on TRICARE. The point I want to impress upon you today is that one of the biggest drivers of healthcare costs is inappropriate utilization and how poorly chronic illnesses are treated in an institutionally dominated medical system. Too often, access to primary care is poor and preventive services are not offered or accessible to patients, especially those with treatable chronic diseases like diabetes, hypertension, and congestive heart failure. These conditions, unless properly managed, will result in costly visits to either the ER or a hospital setting. One avoided ER visit can easily pay for 9 visits to a primary care clinician. One avoided hospitalization funds approximately 90 clinician visits. Vancouver Clinic believes that making integrated ambulatory care more accessible will improve health outcomes while lowering costs for the citizens of Washington State. How healthcare is utilized really matters. In our outpatient setting, we are seeing that our patients with chronic illnesses get more visits to primary and specialty care, and subsequently their chance of an ER visit or hospitalization goes down approximately 40%. When we can safely do a surgery in our ASC, the cost of the patient and the system go down almost 50% for the same surgery done in a hospital setting. I would urge the board to carefully consider how policy can influence the core issue of utilization. We believe this will be more effective than considering blunt-edged instruments like provider rate setting and growth caps. We believe that you will also find that increased investment in primary care and ambulatory services will help avoid wasteful spending on the significant drivers of cost in our system. Thank you for your work on this important issue, and I'd be happy to entertain questions or have the opportunity to speak with you more about this in the future.
Thank you, Mark. I sure hope you will stay with us through the rest of the meeting since our primary care agenda item is coming up. So
I will. Thank you.
Great. Mandy, who's next?
Alicia Eiler.
Alicia?
Hi there.
There you are.
There I am. You can hear me okay?
Yes, we sure can.
Good afternoon, Director Birch, as well as members of the Healthcare Cost Transparency Board. As you know, my name is Alicia Eiler, and I am speaking today on behalf of Fred Hutchinson Cancer Center. As you all know, Fred Hutch is like no other hospital in Washington and uniquely innovative in its care model as well as our financial structure. And because of our special model and the highly complex patients we serve, we do appreciate this opportunity to speak briefly about facility fees. And kind of to Jane's point, as the board considers the broader discussion around our state's health system and facility fees, we do want to be, Fred Hutch does want to be on the record to avoid any unintended consequences to cancer care and innovative life-saving cancer research in our region. So Fred Hutch is the only National Cancer Institute designated comprehensive cancer center in Washington, as well as in the entire 5-state WWAMI region. Currently, Fred Hutch serves more than 53,000 patients every year and only operates 20 inpatient beds physically located at UW Medical Center, Montlake. All other cancer care at Fred Hutch is provided in our 6 clinical outpatient hospital-based clinics. If we can keep our cancer patients out of the emergency room, immunocompromised patients are less likely to be exposed to hospital infections. And for many of our patients, this also means that they can be receiving their cancer care in a setting closer to their home and closer to their caregivers and families. And this is similar to what our friends at Seattle Children's explained. Just for your information, Fred Hutch only treats patients with cancer. We do not have an emergency department. And as I said, these patients are often highly complex in their care that they need. Of particular interest to today's conversation, each year, Fred Hutch is also actively enrolling patients in more than 750 clinical trials. And according to our experts, approximately 1/3 of our Fred Hutch infusion patients are participating in various clinical trials. And this requires incremental monitoring, which far exceeds the necessary expertise that is needed when you just have a standard infusion. And I want to brag, Fred Hutch has some of the most highly and specialty trained oncology teams. And in particular, all of Fred Hutch's nurses are certified by the Oncology Nursing Society and are trained to expertly respond to cancer patients and any reactions that they may have to their treatments. These nurses and other clinical staff are paid and trained through hospital facility fees. Fred Hutch, in closing, is here to be a resource to you in this conversation, as well as how more broadly to reduce the cost of care for cancer patients. We are proud to be the home to innovative researchers looking specifically at some of the things that you are all looking at patient medical debt, health outcomes as compared to the cost of care, high-cost prescription drugs that we're all learning about, increasing diversity in clinical trials, improving access to care for all people with cancer, and so much more. So we really do have these incredible resources that we would love to share with you. And I think that what we're all doing is working together here is to ensure that everyone in Washington has access to the highest quality of care and the new cancer therapies of the future. So thank you so much for listening and for your thoughtful consideration.
Thank you, Alicia. Mandy, Do we have anybody else, or is there anybody in the room or anybody else on screen that would like to provide public comments? I'm not seeing any other hands.
I don't have any other persons noted for public comments.
All right. All right. Board members, because this is a longer meeting, I think it's time to give you a 5-minute stand-up break. Why don't we reconvene back here? Oh gosh, at just in 5 minutes. So 3:56 or so, that would be great. Go get more water, stand up, stretch, and we will dive right back in for a robust discussion when we get back. Thanks. Mandy, I see you coming back on screen, and I see many board members coming back on. Give it another minute. You can do a little yoga in 5 minutes. Not bad. Not bad stretching. All right. I think we're going to go ahead and resume. Do we have Janine? And I see Liz on. Oh, Janine's on as well. So board members and members of the public that are listening in, we just finished a short break, and next we're going to have Janine Smith and Liz Arjun from HMA. They're going to help us by facilitating further conversations and discussion on this topic as a potential lever. Over to you, the both of you.
Sure. I think I don't know if there were some slides for this where we had some questions. Mandy? Nope.
Oh, we're working on it.
Okay. Well, basically, it's some of the same questions that we've been wrestling with, but was to try to get you all to think about what kind of recommendations you might want to consider as you move forward with kind of the two areas of the facility fees in terms of data collection, as well as advance notice as far as some recommendations around what you might want to consider or change going forward. For the transparency, it's really is, do you want to consider whether you would, ask additional types of facilities beyond those currently collecting data via Department of Health to be included in those reporting requirements, such as lab facilities, imaging, other service facilities. I know our ASC participant of the panel noted there was some ambiguity also to potentially consider for as far as non-hospital affiliated facilities, should they be reporting their fees? And then what kind of detail? Right now, we just get a range between, hospital reports, facility fees range from this to that, but we don't have a lot of detail around it. So we wondered what kind of thoughts the board members had in regards to potentially increasing the transparency of facility fees as they're currently being applied in Washington State right now. Thoughts?
This is Greg, Sean, if I could comment. There doesn't seem to be any evidence that transparency makes any difference. So I guess I would hope we could focus on other ways to drive change. I mean, I'm not opposed if there is some distinct value in added data, but it's just going to make the story worse. And yes, we'll have more finite data on something that's already egregious to consumers and plans, but it doesn't drive change.
Thank you for that, Greg. I could kind of feel the same way. I do think it would be great if we could strengthen some of the reporting that's going on ever so slightly and take some action to move forward. Greg, did you have some thoughts about potential action that you'd feel comfortable supporting?
I mean, this is an area that I think could be dramatically right-sized or eliminated. I mean, it's just, as I've said many times, it's just an egregious revenue grab.
I see a lot of heads nodding.
So I mean, I'm not sure an outright. I mean, it seemed like, some kind of leveling the playing field as to what we pay, pay for the service, not for where the service is received. Uh, you know, uh, I'm all in favor of those kinds of approaches, and I think some of the concerns can be mitigated when there's certain situations that put a hospital at risk. Um, I think honestly that's a bit of an excuse, but I also think that should be addressed somehow in order to be a fair policy. But otherwise, I just think it's a great big revenue grab that we should stop.
Thank you. Eileen, I see your hand up.
Well, I just was gonna give a little history, I guess, from at least my memory at this stage of the game. When we talked about facility fees and when we dealt with it in Washington State in 2012, it was Representative Johnson was who brought the bill forward, and it was after a doctor's clinic over in Yakima had been acquired by the hospital. And at that point, I don't remember which hospital it was, but it was because they had two at that time. And they basically made over $1 million out of Yakima in a year and got lots of complaints from patients because they had been they basically got the same care and got charged more. And that's why we worked on it. But, when in the discussions then, part of the idea of the facility fees, that at least what we were told at that point, was that the hospitals needed the facility fees for basically because they run an emergency room and for the facility building the hospital. So we were kind of like, well, then why should we have to, when you're buying or affiliating a doctor's group, that's already been paid for. So that was some of our discussion at the time. And that's why I had the reaction about the freestanding charging and not being affiliated, because ASCs don't have emergency rooms. Yes, they're cheaper. We want to keep them that way. And so that it's what, basically the services that they're doing. So it's like, what's the facility there? Anyhow, I'm just rambling, but it's trying to think about how the discussions we had now 12 years ago.
Well, Eileen, I think your point is a really fascinating and important one. Children's charges facility fees when people go in for a behavioral health appointment. So help me.
It's a money grab. I know. I totally agree with you on
I
that.
can never just reconcile that.
Yeah.
Just like you're sharing now and what you were trying to do from a legislative approach 12 years ago.
Yeah. No, I mean, I think that what's going to have to happen is really analyzing what might, where it is appropriate to have a facility fee, if there is, if it's needed. I think the statement, and I don't remember who it was that talked about, it's like we want appropriate reimbursement. We just don't want, they're supposed to be nonprofits. We do not need, a huge margins being brought up. So that's, yeah. And I also remember when margins for healthcare, if they had a 3% margin, they were happy. Now they all want a 4% margin. So that's the other thing that's creeping up. So, and maybe it's because I've been around too long.
Margaret, I see your hand up. Go ahead.
Thank you. I'm having a hard time figuring out what a possible improvement on this might be without looking at the whole payment system. I mean, this is a part of it. There are so many cross subsidies going on. I know there are hospitals that are losing money. So if you take a big chunk out of what's giving them some benefit, you put them into a worse situation. I don't have information on all the margins of all the hospitals in Washington State, but overall, we know in the last few years, they haven't been very good. So I'm much more inclined to do something more far-reaching and dramatic, like look at hospital budgets and get rid of all this complexity and cost shifting and so on, because it's kind of a whack-a-mole thing.
Appreciate that, Margaret. Other board members, comments, thoughts?
So I would just say, if I might, I totally agree with Margaret's point. I think my issue with this one is just one of so many things that just hits the consumer so hard at times. And there are many, but this is pretty easily identifiable. And just really, really harmful to so many consumers, which is why I get so riled up about it. The other thing, and I would love to do this, for the hospitals who don't like it, they can show us their budgets and their capital expenses and how much building they're doing to create more demand for unnecessary services. None of them will want to do that.
When we had hospital rate setting, did we include facility fees? Were there at that time, that was the end of the 80s is when they got rid of it. But whether facility fees were even allowed at that point or calculated in. Do you know, Jane?
I don't even know that they were a thing in the 1980s, in all honesty. I mean, so a couple of thoughts. In terms of facilities reporting to DOH and changing the way facilities report to DOH, if I had more choice, I would definitely go with figuring out how to modify the all payer claims database to get the information and then require ownership reporting and be able to pair the two rather than mucking with facility reporting of fees. Because what we've seen to date is that it tends to be sporadic, and that what we're getting is sort of so gross meaning high level, that other than saying it's a whole lot of money that's being charged to people, I don't know that it's particularly actionable. So that's the thought on reporting. I think in terms of anything that has to do with consumer notices, it's not worth investing there, because consumers just either don't understand it or they're inside a system. The provider that they're seeing has been told to refer people to providers that are inside the system. And your average consumer isn't going to have the wherewithal to say, but wait a minute, there's another place down the block and I checked and they're that much less expensive. I think that's just not worth putting the effort in. And then in terms of targeting in on, if, Greg, as you recommend, the board goes at facility fees directly, is looking at the list of CPT codes that MedPAC put in their recommendation to Congress and using that as a reasonable starting place, because they have spent years, MedPAC's spent years thinking about this issue.
Thank you for those, Jane. I think that the APCD modification would really be an interesting place to go. And Greg, that might be something that if anybody from the Washington Health Alliance is listening in, that might be something that we try to align between the two APCDs. So we could certainly investigate what that would look like or what other states have done. So there's that monitoring or that, monitoring off the APCD. And Jane, the requirement about ownership reporting would really help Healthcare Authority as well, since we just negotiated full attestations from hospitals on the safety net assessment fee. So I remind you, this was the $2 billion that we infused in for improved Medicaid hospital rates. This time, the federal government required that we got attestations from all hospitals that are participating, saying that they would abide by how the rules work. But we have not got ownership reporting data. It's voluntary. And we have, I believe, only 50 to 60% of the hospitals that are willing to report their ownership complexity. And I think that that is something that we would use at the Healthcare Authority as well for some of the financing maneuvers and network accountability that we all need to pursue. So that would be very helpful. And then I love the idea of looking at the list of the CPT codes from MedPAC. So that trio of solutions feels like a really good mix of greater accountability and then action. Others? Go ahead, Kim.
I guess I'll just add that I do support the activities that you just articulated and kind of recapped. I will add that I found it compelling that, the idea that strategic targeted supports for certain types of providers, of hospitals, healthcare systems that have a particular a very essential mission-driven sort of requirements that we all believe in. I think that, some care needs to be taken not to just throw money somewhere because someone has a compelling mission statement. But I do think that it makes sense that all of the hospitals in the state are not in the same situation, are not similarly situated. And so, I think taking care, I'm not sure the type of analysis that I'm recommending, but it just seems that taking care with, understanding the realities and perhaps some different categories or groupings of providers who are charging facility fees, that we may, if there was analysis to be done, maybe we could see the difference in the sort of the need for the facility fees, whether they're called facility fees in the future or not. People can make up all kinds of names for charging money. And so it's just that there really are probably certain costs that are particular to a certain type of healthcare systems and hospitals that are deserve to be accounted for. But allowing facility fees to just sort of proliferate, everywhere is clearly not appropriate, is not the answer.
Yeah, thank you, Kim. I do think that we absolutely need to look at exceptions or just different classifications, like has been brought up. But we could ask our consultants and staff to come back to us with how we might do that in a better way. Part of that ownership reporting requirement. Mm-hmm. I'm wondering, I don't see any other hands, but I'm wondering how people feel about also urging the use of our public option. Oh, I saw Ingrid just come on, so I bet I just stole her thunder, but I thought that was really interesting since we are the only state in the nation with a public option. If we wanted to experiment with that set of folks, although I always hate when we start doing one-offs because it really makes systems crazy, and I would rather take statewide action. But how do people feel about using the public option as an experimental zone?
Well, I'll just say that probably isn't any easier just to do it on the public option than it is to, having gone through that legislative battle, than it is to do it on a broader, and actually, I'm kind of curious about the state employees, which is a bigger group. That was one of our consultants mentioned using state employees. Because we, as you said, we just infused a lot of money into the Medicaid. We should be seeing the business side of things, which for us is the state employees, rates come down. So that, I guess I'm wondering if we can somehow utilize it that direction. There's not that many people in the public option. It's not, there's a heck of a lot more in the state employees.
Yeah, I mean, I'm assuming you mean the school employees as well, state and school employees. Yeah, that's a good 750,000 folks, and you are right. Public option is we're still under 60,000-ish. Not that that's not important.
I agree.
But I think Zach mentioned going into commercial as being the one to potentially eliminate the fees initially.
Well, I know Greg had to jump off, but I'm sure he would support that idea. So why don't we do this? Let me just check on time. How are we doing on time for more discussion here? Are we good for a few more minutes, Mandy?
Yes, you have a few more minutes, I believe. 4:25, is that correct? Or
that's what the agenda said.
I'm pulling it up.
Sorry, 4:25.
Yeah, so we have what other ideas do people have? We can direct staff again and our consultants to come back and give us some more pro cons, but are there other thoughts? Or I guess I'm getting, like Eileen, I've been around a long time. I guess we nurses who have seen, it just feels like wherever we put downward pressure, it pops up somewhere else. And so to Margaret's point, I kind of wish we could do something more sweeping, but I'm worried that, that's not going to be something that is going to be easy with new electeds coming in. And I think it's just going to continue to take time to convince folks that we are really dealing with a cost crisis.
Director Birch, I'm back. Sorry, our leadership team meeting at the same time, and I know Leah's been listening and engaging. I appreciate the summary she's just provided of where we're at so far. And I think the important thing is we look to take a step forward, that we're already a leading state in this space with the policies that have previously been passed, and looking at how do we have, I appreciate, Jane, your recommendation around how to modify the data so that the extra report is not so bifurcated between what DOH is collecting and what we can see through the APCD. And then honing in on some codes. This fact sheet from the Healthcare Cost Institute was really powerful in showing 3 examples around ultrasound biopsy and physician office visit, and the level of impact on consumers of facility fees. So I think using some time to educate our policymakers about this is one cost driver that contributes to our inability as a state to meet the cost growth target, and that needs attention, but not selling it as a end-all solution. And I think to have an impact definitely would need to be just like any policy, like reference-based pricing would be much more potent if it weren't only in the public option, but in other purchasing groups such as PEBSEB. So looking at both specific fees that are most egregious, and then using that as an opportunity for education and going beyond not just one small purchasing group.
So Ingrid, I don't know if you caught Jane. It was Jane who said, why don't we really look at modifying the APCD, requiring some ownership reporting, and then look at the list of those CPT codes. And I hear you kind of narrowing it, saying, yeah, you like the CPT codes, especially ultrasound, biopsy, and physician offices.
I'm just, yes, and the power of the example of illustrating where we know there are certain codes where this is a particularly potent issue or challenging problem for cost for consumers.
I'm wondering, Michelle and Mandy and Evan, if we asked you all with our consultants to come back and show us the financial impact, if we were to recommend that list of CPT codes or a narrower set, that we could get a magnitude of what that might do. And or like if you guys could come back and talk about what other kind of either rule setting processes or legislation we would need to drive forward this limiting the impact to consumers.
We'd be happy to come back with some pro cons on the items talked about today with regards to the board members.
And I see Edwin, your hand went up. I didn't see if Kim was first.
I think Kim was first.
Kim, go ahead.
Well, I just wanted to say, of course, we want to keep track of an unintended reaction or consequence of just increasing the facility fees elsewhere. That, you know, if we are focusing on certain facility fees, prohibiting them, putting some kind of, you know, limitation or restriction, to your point made earlier, we don't want to just incentivize, you know, bumping up the facility fee rate associated, you know, somewhere else. So, I mean, I think that's part of just being, anyway, I think we understand the point. Just we have to watch for that whole, what you just said about pushing one place and then, you know, out pops something else. I think that's likely. It just seems like something that to really watch for. The one other thing that I thought was really interesting was very concerning was the point made earlier. I think Zach made it, or someone perhaps, about the consumers being hit with sort of double point of service cost sharing, you know, having a copay apply, but then having coinsurance apply when the person is really seeking and receiving sort of one service, but then they're responsible for two different types of cost sharing, and it would, in their minds, of course, it's they owe a cost share, but one, you know, they owe a copay or they owe coinsurance, but to actually be technically required to be responsible for both. That I hadn't thought of that before as a part of the facility fee world. So I don't know if I understood what was being said properly, but certainly that's something that maybe there could be a positive effect for consumers if that possibility was prohibited. And I don't know what it would take to do that, but that just seems particularly inappropriate.
So again, maybe we could direct staff and our consultants to come back with some guidelines around how, again, we could really try to put some boundaries around the use of facility fees. I think Edwin and then Jane.
Thanks, Sue. So in terms of levers, I was going back to some of those slides. I think our speaker from Georgetown, I think there's a really nice slide in terms of different reforms that states have undertaken. I was wondering, just in terms of thinking about things that might be more successful or things that might be less successful, I wonder if you follow up in terms of a review, or if there's something that could inform. I think she lists 6 reforms here that kind of cite some of the evidence around these, if there is evidence that could help some of our decision making here internally. And then just the second point, it's sort of do echo, I think Kim brought this up in terms of learning more about potential unintended consequences. I think maybe another way of me stating what she was stating in terms of if there's unintended consequences around access or care quality. They could be interested in learning more about that.
Thank you for that. I know Janine and Liz are taking notes. Jane, your hand was up, but then it came down. Are you good, or did you want to comment?
Just a couple of quick thoughts. Edwin, to your comment, Connecticut is really the only state that has enough years of history of regulating facility fees to, I think, get a sense of what the experience has been. And Connecticut's got much more extensive reporting than we do. So indeed might be worth it to reach out to them and see. And then Kim, to your point, I mean, one way to think about it is how can we pair if the board does move forward with this recommendation about limiting facility fees? How can we pair what kind of sort of oversight and monitoring is going to be going on via the APCD, via the Washington Health Alliance, to really take a hard look at what's happening generally to outpatient hospital department pricing, and whether we see that the base rates just end up going up because it's been shifted to another place.
Thank you for that, Jane. It's a little depressing, but thank you for that. Validating what we've consistently seen. Lois, I'm going to let you have the last question or comment, and then I think see if Janine and Liz have enough to go forward with getting information back to us. Go ahead, Lois.
I'm the outsider to all this healthcare stuff, so forgive me. I'm wondering if there's a way to determine who's making egregious amounts of money with this, and figure out what it is that they're doing. Like, where can we find the problems through what they're doing, the people that are causing most of the problem? Would that be another way to look at this? That makes sense?
Yeah, I just think with the kind of the limited data reporting we have currently, systems would have to work with us. And I think until we have agreement on kind of a direction, I'm not sure if they would voluntarily come forward. But we can certainly, again, ask staff to think about some creative solutions there.
Yeah, thank you.
All right, Liz and Janine, do you feel like you've got enough to come back to us with some more specificity? Because again, the 4 or 5 things I have, the modifications of the APCDs, the requiring ownership reporting, looking at the list of codes from MedPAC, looking at PEB and SEB modeling and what that might do, and then learning more about the unintended qualities, looking to Connecticut to see what it did to quality and or were there deeper lessons learned out of Connecticut. Those were the 5 things that I think I heard people kind of gelling around.
I think the SEB and PEB is related to where you might restrict, eliminate fees as opposed to site neutral payments. I mean, there is one thing we didn't talk about was site neutral, where it's the same fee wherever you are. So.
Oh, so that would, so maybe add that as a 6, the proposal about how we just do a state flat rate, site neutral fee. I thought she said no state had done that yet, so I bet it's going to be really hard.
They're in development, so we probably wouldn't. But that was the federal initiative we're monitoring. But we can certainly take a look at the MedPAC diagnoses and see. It is hard, though, I would think, for some of the impact for us to calculate it since we don't have all the data, but we'll see what we have and what we can bring forward, and then being aware of the unintended consequences and what Kim was pointing out about sort of the unique mission entities, if there's any thinking about that.
Margaret, I see your hand is up. Go ahead.
Thank you. I get a little nervous about using the state employees and teachers programs for experimenting, in that there could be some unintended negative consequences. And we compete for, the state competes for good employees. And I think we have to be careful to not use them for policy ends if it would bring them some disadvantages. So that's just kind of a warning on those programs.
Thank you for that. And I think, again, staff are going to come back to us so we can go deeper into conversations and see if we still support moving any of these forward in our report out. So thank you for that cautionary note. All right, I'm going to move us on to our next item of business. Thank you, Janine and Liz. And I know you'll be back at us. All right, nominating committee recommendations. This is tab 8. And who am I turning this over to? Kim.
I'll do that. Yes, I'll share on behalf of the nominating committee. This is with regard to filling 2 positions, one on the Healthcare Stakeholder Committee and one on the Data Issues Advisory Committee. And so next slide. The nominating committee met a couple of weeks ago. That's Ingrid and Carol and I. And we reviewed information with regard to 2 members, 2 new members. We also reviewed a newly developed advisory committee application form that kind of captures a uniform set of information for people who are expressing interest or who are being suggested or recommended for membership on an advisory committee. And I think that's a good step to take because it sets a stage in a more sort of uniform and gathering comprehensive information on every individual. Some, as we've mentioned before in this meeting, some people who are interested in membership on advisory committee with us are quite well known to some or many of us, and other individuals are not. And so we want to make sure that we're really, fair and open and really do, sort of a good job of considering all the factors and information that someone is submitting, either for themselves or on behalf of someone else. And then we did choose, then we voted to send 2 people, recommendations for 2 individuals to join committees. Next slide. This is a refresher about the Healthcare Stakeholder Advisory Committee. There was a update to the membership sort of requirements for this committee, as you recall, in the last session. And specifically, we are now presenting to the board an individual, Michelle Ratala, to fill an employer purchasers representation representative seat. She is being nominated by the Purchasers Business Group on Health, and Michelle has an awful lot of relevant experience in managing employee health benefits, and she is currently with King County Department of Human Resources. The other committee nominee is David D. Giuseppe, and he is currently the Vice President of Healthcare Economics at Community Health Plan of Washington. David also serves on the Universal Healthcare Commission Finance Technical Advisory Committee. So Michelle and David are being recommended for membership on the Stakeholder Advisory Committee and the Data Issues Advisory Committee, respectively. Next slide. Oh, and then we just have some additional information in the packet, lots of wonderful information about Michelle and David. Go ahead and go. And this is also in the packet. It's a review of an update regarding the current membership. So the board can see, who is on the committees now, their representation, the current position or post that they hold. It's hard we've had some changes, and updates to the committee membership. So we thought that was really helpful to have that. This that you're seeing on the screen here is just a background piece related to the application. Describes the kind of information that we're seeking to support nominations. And let's see, that's what I had to share. And I think we're ready for, questions, discussion, and then a vote to approve the two new nominees, Michelle and David.
So first, Kim, Lois, and I think Ingrid, thank you for filling this gap and getting this committee structure in place. That's fabulous. Are there any questions from the board about this recommendation? And if there isn't any discussion or any proposed changes, is there a motion to approve the recommendation?
So moved.
Thank you, Lois. Is there a second?
Second.
Thank you, Margaret. All in favor, say aye.
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 Any opposed? Okay, the motion is approved. Again, thank you, Kim and team, for moving us forward. Next, I would like to welcome Dr. Judy Zerzenthal, our chair of the board's primary care committee. She's also the Healthcare Authority CMO, and she's going to present the committee's recommendations for the board's consideration. So here is our other big agenda item. Go ahead, Judy, over to you.
Excellent. Thank you. I will be on camera shortly, but I am delighted to present to you the results of the 12% primary care subcommittee recommendations to be voted on and approved for inclusion in the legislative report. So next slide, please. So as a reminder, in 2022, the legislature directed the board to build on previous efforts to define and measure primary care spending. We have been to you previously with our new updated definition. And this presentation and the recommendations today are all around how to increase primary care expenditures to 12% of total healthcare expenditures. Next slide. So why do we want to do this? As a reminder, primary care is a fundamental part of the healthcare system and provides an entry point for patients to get prevention, to get chronic disease management, to get acute care, to get behavioral health. And the research shows that access to primary care for over, I would say, 2 or 3 decades, the research has shown this, that access to primary care is associated with improved health outcomes, with increased equity and higher life expectancies. And so over time, expectations related to primary care service delivery have increased while everything else has stayed relatively constant. Maybe even specialty care has increased. And so that has really led to sharp reductions in the primary care workforce and limited access to care. And here in Washington, we definitely have metrics around primary care access, around quality, that are not as good as other states. And there's a lot of strong evidence that shows the value of investing in primary care to get to those higher and better health outcomes and better quality of care and decreased total cost of care. So next slide. As you might remember, we developed 4 key areas to evaluate primary care expenditures. I'm going to start with direct investment, which is paying more for primary care services. The second category is reduced expenditure on other things. So maybe by having primary care, you get fewer ER visits or fewer hospitalizations. Patient behavior is increasing patients' use of primary care services, and then capacity growth is figuring out how to invest in the workforce and how to reduce administrative barriers so more care can be, more time can be spent on patient care. Next slide. So as we were figuring out how, using those 4 domains, how to get to the 12% primary care spend, we developed the following principles that we thought any policy recommendations our committee came up with needed to abide by. So first is an unambiguous linkage between the policy and achieving that 12% target. Second is clearly defined action and people who take that action. Third is policies are financially, operationally, and politically feasible. And finally, the policies result in both improved access and quality, not just expenditures. And so on the next slide, we have 7 policies. I think we brought these in an early stage to you that we have been evaluating to increase and sustain investment in primary care. And as a spoiler alert, we are going to recommend all of them, 2 of them to take action on and 5 of them to support because there's already ongoing action in those places, and so to just continue that. So we're going to dive into each of those as I go on with the presentation. So next slide. So I'm going to review a summary of, or this is how we went through each of those 7 recommendations. We sort of had a deep discussion on each one. We voted on whether we wanted to continue this or not. And then at our last meeting, we voted on final language for each recommendation. And that is what's coming to you all today as the board. So any questions, or I'm going to kick it off into our recommendations. So number 1 is increased primary care expenditures. So this recommendation is to recommend to the legislature to codify a goal to increase primary care spending by 2 percentage points a year. We had originally had this by 1 percentage point a year. The committee pretty unanimously felt like that was too slow. Other states have done this, but they really wanted to make that happen. And as a part of increasing the primary care expenditures, there's a recommendation that the legislature require agencies to publicly report primary care expenditure rates, including HCA, the Exchange, and OIC, and recommend that the Office of the Insurance Commissioner submit a report to the legislature proposing how payers will be accountable for achieving primary care expenditures. There was definitely a feeling that just publicly reporting transparency measures may not lead to behavior change and may not get us to our ultimate outcome. And so they wanted discussion of what teeth OIC could maybe have to increase the primary care spending. So the next slide is about why this recommendation is important, that small increases in the percent of total spend require a lot of increase in primary care reimbursement when holding utilization and total expenditures constant. Actually, I'm sorry, I think that's flipped. Primary care expenditure is already a small part of the total cost of care, and total expenditures have a lot of moving pieces. And so ideally, by increasing primary care reimbursement, will increase the utilization of primary care services that in turn decreases the utilization of other service categories, in particular ER visits and inpatient care. Questions on that, or shall I just keep going along? I know we're short on time.
I'd keep moving us along since we've seen some of these before.
Okay.
Oh, Eileen has her hand up.
Just a quick,
yes.
do we know, as a former legislator, do we have a fiscal note? Do you know how much 2% would cost us?
I do not. Yes, that is a good question, especially I don't know that we have a fiscal note for the other areas. We are considering a decision package this year to increase Medicaid rates, but not on the PEB-SEB side. And, I'm not sure what the commercial side would be.
Eileen, you're muted.
You're on mute.
Sorry, I thought I hit it. Knowing that so that we can prioritize, I think, is kind of important.
Okay.
This is Jane really quick. If the board is interested in moving forward on what was on the previous slide, Eileen, we could try to put together what it would take to sort of ramp up the rate review to be monitoring those things and or other reporting.
Yes, I do think that if these recommendations are approved, then we can sort of start the work of what does that look like. And we definitely have had conversations with Jade and her staff about how does OIC have carriers report on primary care spend. So this would be another step in that, but I think doable. Okay, I'm going to move on to recommendation 2 of increased Medicaid reimbursement. This recommendation is that the legislature should increase Medicaid reimbursement for primary care services to no less than Medicare rates by 2026. Initially, this recommendation was by 2028. And the how to do this is that the legislature should direct HCA to implement the increase using the enhanced adult primary care and enhanced pediatric fee schedules that are already existing, and revise those fee schedules to more closely align with the primary care definition. It is pretty close, but not exactly there. And that any services on those enhanced fee schedules that are already above Medicare should stay there. This is actually we have a decision package that's being made to recommend this to the legislature from HCA to enhance Medicaid rates to Medicare. The fiscal note for that is currently under construction, and we've been doing stakeholder review for this. So this is one of the things that HCA hopes to move forward. And why this is important is that the connection between higher reimbursement and both an increased ratio of primary care expenditures, but also better access is a plausible and sort of understandable way. And there may be additional positive effects for equity and workforce stability. So recommendation number 3, those first 2, as I said, were actions. And then these last 5 are endorsements of work that is already going on that the committee felt like they wanted to endorse so that it keeps going. And so this first endorsement is on multi-payer alignment, and that the committee endorses that the multi-payer collaborative has work ongoing that is aligning standards, quality metrics, practice supports, and payment models. This is also aligned with making care primary, and that we should continue to support those multi-payer primary care alignment efforts to make more progress on primary care. Why this one is important is that there is momentum both with Medicare and making care primary and with current work going on, that there are shared goals. And recently, the multi-payer collaborative came together, signing a memorandum of understanding, committing to primary care. And that by having this alignment, I think there's reduced burden for both providers and payers that will allow practices to advance transformation and advance primary care faster. Number 4 is patient engagement, and the committee endorses the healthcare authority's efforts to participate in making care primary and the primary care transformation initiative, and that any state agency efforts to support the availability of incentives for an employee or a member to access primary care services should be used. And so thinking about how do we encourage people to select a primary care provider and seek care from them. And why this is important is that employers, insurance carriers, providers, and patients all have a role in patient engagement to get preventative care and to participate in their own care, which makes management of chronic disease more likely and successful. And that will help us meet our goal. Recommendation number 5 is about workforce development, and the committee endorses the Health Workforce Council recommendations that would increase access to primary care services. This one is important because we know that we have workforce shortages that create a lack of access to primary care. Washington has fewer physicians per capita, including primary care, and many of the primary care physicians don't work in primary care anymore, but work other places. And so people who don't have access to a primary care provider seek care in the emergency department. Our behavioral health workforce shortages could be helped by stronger primary care that would allow the behavioral health workforce to serve folks with more complex needs. And then also this would help with shortages at long-term care facilities in helping with discharge and having primary care folks involved in that. Recommendation number 6 is the use of alternative payment models. So the committee endorses the Healthcare Authority efforts to track and set targets for primary care expenditures using the Healthcare Payment Learning and Action Network alternative payment framework categories, with the goal of increasing the percent of primary care expenditures that are paid through either population-based or shared financial risk-based payments. HCA already reports on expenditures in these categories, and there's a desire to continue to report on that and share that information with the Primary Care Advisory Committee so that recommendations can be fine-tuned. And why this is important is that value-based payment is a range of payment strategies that are intended to contain costs while improving outcomes and improving quality. There is a variety of mechanisms to do that, and they will likely be successful in helping a practice deliver care in different ways. Finally, recommendation number 7 is a measurement strategy that the committee endorses the efforts by HCA to measure expenditures both on a per member per month or a per capita basis, as well as primary care expenditures as a percent of total expenditures, and to make future recommendations to improve primary care expenditure tracking based on any findings. And so this one is really about when the legislature established the 12% expenditure target, it relied on the experience of other states, including Rhode Island and Oregon. And that 12% expenditure target does drive investment in primary care, but in talking with both Rhode Island and Oregon, they wished that they had set it up as a per member per month or per capita expenditure target so that that primary care investment isn't inappropriately influenced by either changes in price or utilization of other services. It more accurately reflects the amount of money and the investment that's happening in primary care. And we thought that that is a worthwhile thing to investigate, but that it actually probably needs more time to sort out, and that the important part was starting to measure what percent spend we are of primary care and work on that with a goal of switching to a per capita spend at some point in the future. So that is the package. Next slide, please. So the first, next slide. The first two are policy recommendations for the board to consider of increasing primary care expenditures and increasing Medicaid reimbursement. Both of these require some legislative action. And then the last 5 are committee endorsements because they're strategies that are already underway or can be implemented without legislative action and by continued work. And so I don't know if there's other questions or comments about this.
And Judy, I see we're running close to time. So board members, are there? Oh, Ingrid's got her hand up. There's a question.
Dr. Zerzan, thank you so much to you and the committee. This all looks great. My only pause is in the number 1 and 2. I just think we need to sharpen our pencil on the messaging and also understand a little bit more about the mechanics so that no one interprets this as an increase in overall healthcare spend, that it's a no net increase. It's proportionally spending more on primary care and less on other types of care. Or if that isn't the case, or the intent behind the Medicaid reimbursement is giving some indication of funding source so that we know if there would be unintended policy consequences. You know, for example, just an increase in premiums in our market could result from just overall net increase in spending. So those two just I need a little clarification there.
Thank you for that. Edwin, I think you were first, and then Jane and board. It looks like we're going to be going over because 5 minutes. Can I see a thumbs up or a head shaking if people can hold over 5 minutes? Yes, yes. Okay, go ahead.
Thank you. I had something thinking along the same lines, sharpening the pencils around 1 and 2, and just one, maybe some evidence around that. I think there's actually a public comment around pointing to some evidence around how good access to primary care can avert or avoid things like ED visits, hospitalizations, which I think there's a statistic it could pay for like 10 one ED visit could pay for 10 primary care visits. I think evidence around that I think could help, among other things, sharpen number 1 and number 2.
Thank you, Edwin. Jane, and then Margaret.
Okay, so a couple of things, Judy. I'm trying to figure out how recommendation number 3 works with recommendation number 6, right? So is it, we just want to use any APM for primary care, or is it that we want to bring APMs together into multi-payer arrangements? Given that report that I sent you about physicians' unwillingness to participate in alternative payment models, seems like that really big focus on multi-payer alignment is like the big thing in here. And then in terms of things requiring legislative action, I'm not sure how closely you've looked at whether going to a PMPM, primary care expenditure measurement, is something that you would want to ask the legislature to amend the law to reflect, rather than just going with 12% gross spending. So just a couple of quick thoughts there.
Yes, that last one for sure would need legislation because it has a 12% is in the legislation right now. But I think there's a little more understanding that's needed before we would ask. I think we need to measure what that per capita spend looks like and figure out how to do that to make sure that it's feasible and that it's meaningful before we would ask the legislature to do that. So that's why it's an endorsement, because there's more work to be done in talking about that before asking for legislative action.
Thanks.
Final comments. So I know Judy is hoping that we can move for a vote of approval of the recommendations from the primary care committee. Is there any further discussion or recommendation changes, proposed changes to these recommendations? And if there's no further discussion, do we want to?
I think Eileen has her hand raised.
Oh, Eileen?
I just, I'm just paranoid. I'm uncomfortable accepting without knowing the price tag on things. Is there any way we could modify, or like when we make the motion, having it come back to us with the money, that we endorse the idea, but would prioritize what we want to see. I just was on the appropriations committee way too long.
So I hear Eileen saying that she would like to see the promotion of these suggested recommendations with final kind of approval once we have more information on number 1 and number 2.
I think another way to potentially do it, Eileen, is to ask the legislature to consider increasing the primary care expenditures, or to set a goal and have that go through the legislative process. And so they could decide whether that was something they wanted to do or not. I also think it is worthwhile, to Ingrid's point, thinking about whether this is new spend versus changing with existing resources and to get there. I think I actually personally think the 2% spend increase per year is a stretch goal. I think that's a lot. I think a 1% spend increase per year is a little more feasible, because that's what other states have done, and they've been able to achieve that. And I think the committee was quite gung-ho in wanting to move faster. And I recognize I don't know that that's totally feasible.
Eileen, would you feel more comfortable if making a motion if it said explore primary care expenditure increases and increase to the Medicaid reimbursement, like with more information? Would you feel?
Yeah.
Be added?
No. I mean, I totally agree with the goal. It's just, what can I say? I've just learned and want to know how much something costs before I buy it.
Okay, do you want to restate that in a form of a motion so we can keep moving forward?
Can I just say, as you, that I move that we endorse the goal? I'm trying to figure out how to phrase it. And come back with more information before we have, or is that what does that sound all right, Judy? I'm just trying to.
Yeah, I mean,
I don't know. Is this your final meeting of what goes into the ledge report? My understanding was that we needed to get this in so that we could put something in the legislative report about wanting to do that. And I think the first one, I would say the action that we'd like to take, and there could be some flexibility, so maybe changing it to this, is that the legislature put some dates and goals around it. Right now, that 12% spend is just increased to 12%, and there's not any time bounds to it of like by what date, and there's not any like sort of interim goals. And so the real goal, I would say, of this first one is to start making progress on it, rather than having it be sort of a mushy target that people say, oh yeah, primary care spend is good, but to really start making progress toward it. And I will say that we won't have our first measurement on this until next year, once we get all of the cost board information in, because it's tied to that data call. So there won't be anything really to be able to say how much is this going to be and what does that look like until we have data next year.
Okay.
So Eileen, let me help you out. What if we, the motion is something to the extent of the committee endorses investments in primary care. We support the, oh, my computer just blacked out. Can you hear me?
Yeah.
Yes.
Okay, sorry, that we support the committee endorsements 3 through 7, and that we encourage staff to move forward with modeling and trying to improve or explore increases for primary care.
Well, it's encourage the legislature to do, basically to do the first two.
So instead of saying increase, just say encourage. Encourage.
Well, yeah, I think it's for them to set the goals, to have a timeline.
But
that's really what you're after, right, Judy?
But Judy,
it is, yeah.
But Judy, in 5589, didn't the legislature say that the board should sort of, I'm thinking about, right, the way we approach the growth expenditure targets, right? We said over these years, we're going to gradually, this is what we're going to do year by year by year. Is it the board's role to do that, or is it the legislature's role to do it? Or should the board bring something to the legislature to say, this is what we think a rational way to get to 12% is? And I know it's last minute, and Sue, I mean, if there's a little more time to develop 1 and 2, I think that would be good. And I'm sorry if I'm throwing what's it called? A chink in the works or something.
And I'm going to look to our team and consultants. I thought that Judy needed some action here to keep the decision package moving along, and that we needed to give a signal that we endorse this movement into primary care. And we clearly are all comfortable with the committee endorsements. I think that verb of increase primary care expenditures, we want to do that, but we need that done with more modeling, and we need to understand that better.
I think that there may be some time for us to investigate this. I cannot make that guarantee, but we will see what we can do between now and the next meeting to clarify this issue for everyone and see if we can bring some information back. And then,
well, how about if we have the motion be that we support the 3 through 7, and we want to move forward with the first 2, but we also want to make it budget like a healthcare expenditure neutral. So we kind of go that direction. Does that get us?
I want to concur with that, and I think there's just some small word changes that we could get strong alignment on all of this. And the word I have 2 words to suggest is increase the percent of healthcare expenditures spent on primary care to 12% over whatever X amount of time, and then increase relative Medicaid reimbursement compared to other blah, 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 blah. So because otherwise these 2 things look like it's just, instead of proposing to put downward pressure on healthcare spending, we're recommending spending more on healthcare, which seems very inconsistent with the board. And I don't think it's the intent. So recommending to the legislature and then including some qualifiers to make sure it's clear that it's about percent of expenditures, not increasing expenditures.
So we work by consensus process. Is there further discussion of what Ingrid and Eileen are suggesting? Okay, so is there a motion to approve that recommendation?
So moved.
Thank you, Eileen. And is there a second?
Second.
Great. All those in favor say aye.
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 Anyone opposed? All right, so we will look forward to getting more information back, but I think, Judy, that signals that we are moving in the direction with you. We just want a little more specificity. I appreciate that you all have hung in there. There is a quick item we need to do before we adjourn. Under the appendix, there is an updated ASI report. We would like to include this report as part of the board's upcoming legislative report. However, we would also like to provide members another opportunity for feedback to the report. If any of you has feedback, board members, please submit that feedback by August 15th. But because board members have already provided feedback, we'd like to vote to include the ASI report now, and we will incorporate the board's additional feedback if there is any. And I remind you, this is our analytics support initiative. Is there any discussion of this proposal or suggested changes to that proposal?
I move we adopt the report.
Okay, so I just heard a motion to include the ASI report as a part of the board's legislative report and that you will get your feedback to us. Is there a second to that?
Second.
Thank you. All in favor say aye.
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 Any opposed? Okay, we're approving that motion. Thank you, everyone, for attending this very long meeting. We really appreciate the time that you give to all of this. And I remind the public that the recording and the summary of this meeting will be posted shortly on our website. Thank you to our public members that hang in there and go through this process with us. Our next meeting will be on September 19th from 2 to 4 p.m. And I look forward to seeing you all then. And there is breaking news coming out too about both Delaware's cost board being sued by a certain hospital. And also there are now federal filings for PBM violations or employers being sued for not monitoring prescription drug pricing. So it is Wells Fargo is sued over their employee prescription drug costs. And I understand that there are 15 to 20 other cases lined up in the federal courts. So we'll be monitoring all this and continuing to weave it all into our work. Thanks, everybody. Have a good evening. Thanks to the staff.
Thank you very much.